We are live now.
Yeah. Very good morning to all of you. We are now live on KFOG Update, the second edition of the same. Today, Sunday, 23rd of August, 2020. As we begin this session, we shall begin with an introductory talk by President of the Kerala Federation, Dr. Ambuja Madam. I request Dr. Ambuja Madam to give her opening remarks.
A very good morning to all of you, respected senior obstetricians, distinguished speakers of the day, and my dear friends. On behalf of KFOG, I'm happy to welcome you all to the second update of Kerala Federation with another team of esteemed speakers. We had the last update on July 19th, and it was wonderful. As you can see, we have got eminent speakers today, all experts in their own disciplines. I'm happy to welcome all of them, Professor Pratap Kumar sir, Kurien Joseph sir, Indrani Suresh madam, Dr. Pratima, Dr. Bhaskar Pal, and our own Sekharan sir. We also have our team of moderators from our state. We actually miss your live presence here, but we are happy to see you all on screen in this virtual platform because this is the only way forward in the current scenario. But I should say that all the societies of Kerala Federation are continuing all the academic activities in their own way every other day. There are a lot of webinars going on, and it is a wonderful opportunity for us obstetricians to update ourselves. So I really hope that today also we are going to get a lot of key messages to update our knowledge. And I welcome all the participants to this webinar. And I'm happy to announce that we have got 2 credit points from ICOG. And I'm thankful to Dr. Mandagini Meg, the ICOG chairperson, for giving us this. So thank you all. Jai KFOG. We'll start the session now.
Thank you, Ambuja Madam, for having delivered the opening remarks. Once again, 2 reminders. One is this CME today with such eminent faculty carries 2 ICOG credit points. Big thanks to ICOG, Mandagini Meg Madam, Parag Bindiwale sir, who has taken a lot of interest, and every KFOG program, he is making sure that we get it accredited by ICOG. It's a reflection of the quality of the faculty that we have, that for this short session of ours, he has allotted us 2 ICOG credit points. We also place on record our thanks to the Senora division of Sun Pharma, who have been very enthusiastic and supportive of this program and initiative of KFOG. Without any further delay, we shall proceed to the scientific session. The first talk of the day will be given by Professor P.K. Sekharan sir. To chair this session and to moderate the question and answers for this session, we have 2 eminent faculty, Dr. P.K. Shamala Devi Madam. Welcome, Madam, as moderator. Madam is one of the senior members of Kerala Federation of Gynecology, Obstetrics and Gynecology. She's a retired professor and head of department of SAT in Trivandrum. And like I said, she's senior, very active member of KFOG. Similarly, it's my privilege to invite Gracie Thomas Madam, who is the president of the Cochin ONG Society, also to moderate and chair the session and talk given by Sekharan sir. I hand over the session to the moderators. And I request P.K. Shamala Devi Madam to unmute and please introduce Sekharan sir. Shamala Devi Madam, please begin by introducing Sekharan sir.
Madam, please unmute, madam. Yes. Madam, can you hear? Madam, please start the session, madam.
She is talking, but we can't hear her.
Maybe there is an issue with the microphone on her side suddenly, so that is why her audio is not coming.
Because Shamala madam is not audible, I shall do the introduction for Sekharan sir. Sekharan sir, MD, he is the former professor and head of department of the obstetrics and gynecology, Calicut Medical College. Sir was vice president of FOGSI year 2010 and president of the Kerala Federation of Gynecology 2003 to 2004. Secretary and Treasurer, International Society for Study of Gestational Trophoblastic Disease 2013 to 2017. Chair, World Congress of Gestational Trophoblastic Disease year 2009. Delivered many memorial orations. Is visiting professor of the Peking University, Beijing year 2018. Member of the FIGO writing group on gestational trophoblastic disease since 2015. 36 publications in international and national journals and chapters for PG textbooks. And he served as a feather on his cap. He has served as a captain in Army Medical Corps and active participant in 1971 Indo-Pak War. I don't think many obstetrician gynecologists could have such a feather on their cap. And most importantly for us, he is one of the pillars and most active members and the pillars on which the foundation of the Kerala Federation of Obstetrics and Gynecology rests. Sir, I hand over to you for your talk on for the next 20 to 25 minutes. Sekharan sir, all yours. Please unmute and begin your talk. Sir, please unmute yourself. Sekharan sir.
Yes, thank you very much, Venu, for that wonderful introduction. Respected President of KFOG, Professor Ambujam, and Secretary Venu, and my dear colleagues,
You sure?
Again, from the back end, sir, I think there is some internet issue on the side of the speaker.
He said connection as I do.
What has happened?
His connection has dropped.
Is it?
Yes.
Okay, then I think what we shall do is, if it takes time, is Bhaskar sir there online?
He has joined.
Bhaskar sir, are you online? What about Pratap sir?
Yeah, I'm here.
Yeah.
I'm here.
Pratap sir, could we have your session, because something has gone, some problem with Sekharan sir's session. So could we go ahead? Are you prepared for your talk?
Yeah, I'm ready. Yeah.
I think Pratap sir is ready. So just as in the transition, I hand over the session to be chaired by Paili sir and Raghavendra Prasad. I think Raghavendra Prasad is not logged in. Paili sir, I request you to introduce Pratap sir. Please unmute and introduce Pratap Kumar sir. Paili sir.
See, you have put on the screen, so yeah. Can you hear me now?
Yes, sir.
Yeah, good morning. It's my pleasure to introduce Pratap, and his introduction slide, I'm sure you'll be able to see there. I don't want to go through all that because Pratap is known to us for such a long time, and he has been probably the mentor for innumerable obstetrician gynecologists in the country and abroad. But more than any of those, his contribution as an academician from South India is what stands for in my mind. And I have a little regret to announce publicly, we tried at least to honor him with a fellowship of the Royal College, which did not come through. I even now feel very bad about it. He deserves much more than the awards and public awards that are shown here, like the Fertivision 2018 Durusha Lifetime Award and Foxy, DK Tang, all that. But more than any of these, I think he's known for his academic caliber, his motivation to the innumerable students who have gone through Manipal, and of course, even for some time, he was there in Malaysia, I think. But at the moment, still continuing to serve, especially focusing on the assisted reproductive technology techniques in South India, one of the pioneers for that in the whole country. Pratap, thank you very much for joining us and to tell us on this very tricky question or tricky subject of preterm labor. I'm sure there will be a lot of controversies coming up. We are looking forward to your clarity of presentation on preterm labor. Over to you, Pratap.
Thank you very much, Professor Piley, sir, for introducing me, and KFOG for inviting me, Dr. Ambujam and Dr. Venugopal. I'm only going to talk about risk assessment and prevention. I'm not going to talk about preterm labor because I think prevention is much more than, that's the best. We always say, you know, do that so that you don't get into preterm labor. I bring greetings from Manipal. We all know preterm labor is a huge number, contributes to 1 million neonatal deaths. And the largest number of preterm labor is in India, and about 3 million per year. Now, if you look at this pie diagram, you'll find that the spontaneous labor is about 30%. Unexplained, we just don't know why they get into labor. And another equal 30% is they come with rupture membrane. And another about 25% with infection. And then we all know preeclampsia, diabetes, etc. will cause preterm labor. But look at that unexplained is 30%. So we have to go through these guidelines. I went through all these guidelines in the last few days, and I realized that it is Europe, Australia, French, FIGO, whatever you call it, they only talk about cervical length. And the cervical length has been a very good assessment for these kind of patients. But they also said, if the cervix is 2.5 centimeters, it is a warning sign. It just goes beyond certain times 1.5, but most of the time 2.5 centimeter at around the anomaly scan, I think we should be worried about that patient. And they all said, start progestogens to prevent preterm labor in whatever way you want to do, if you find the cervix is short. That's why I summarized all these guidelines in just 30 seconds. But the issue is, should we do for everybody cervical length? That's my doubt always. And that's the doubt for everybody else too. The answer is complex. It raises 3 issues. Because there's a low prevalence of short cervical length, less than 24 weeks, the incidence is just about 1.7 to 2.3%. So should we do thousands and millions of people who come in for antenatal checkup? It is necessary to screen about almost 500 plus cases to avoid one preterm labor. That's number 1 issue. Number 2 issue is, you'll find the cervical length, the development of the quality standard. That means we should be actually training people to measure the cervix. I'm finding anybody and everybody is measuring. And over the last couple of years, I've found a lot of cervix which is very short, which is actually not true. I call this border effect. You know, it's like India-Pakistan border. We don't know exactly where that border is. You push it a little bit that side and this side and say that's your border. So that is a border effect. Exactly where to put the marker is important for the ultrasound person to do. Everybody is measuring wrongly according to me, unless it's a fetal medicine person or it is an expert who's doing only that for half the time of their antenatal time. Now, because of that, the third problem is you measure everybody's cervix as short and you start giving them bed rest, you give them progestogens and unnecessary intervention. You're branding a normal person as abnormal by doing universal screening. So the unselected population is, in a prospective multicentric study of almost 40,000, The cervical length between 22 to 24 weeks was normally distributed on average of 36 millimeter, means 3.5 centimeters, and the less was 1.5 centimeter. They found those who had less than 1.5 centimeters in 40,000 patients was only 1%. It again tells us universal screening. Are we right in doing for everybody walking in? So what should be the ideal concept then? If the screening was to be considered or is to be considered, only one measurement should be done around 18 to 22 weeks, which also is not recommended by Royal College of Obstetrics and Gynecology and the National Health Services of UK, which I'm quoting. They are not doing for low-risk pregnancies. A low threshold of cervical length should be retained to minimize the false positivity rate, because 15 millimeters means 1.5 centimeters. It will be once again, just about 1% of all these kind of patients. It is published in Best Practice 2019. Now, interestingly, UK NHS brought out this. Last year, March 2019, they brought out this very beautiful literature and Saving Babies' Lives version 2. So, Saving Babies' Life version 2. They have taken 5 chapters in that, which you can read online. But I'm only going to talk about preterm predicting. What they clearly said is there are 3 P's. They didn't say 3 P's. I made it as 3 P's. It is prediction, prevention, and preparation. So prediction is the one which I'm going to talk about. Prevention is a combination of the both. And of course, the third one I'm not going to talk about right now when they come in labor. So the Saving Babies' Lives Care Bundle version 2 clearly said, assess all women at booking for the risk of preterm. That means history taking is the most important. Categorize them as low, intermediate, and high risk pathways. All women to be offered screening for asymptomatic bacilluria. You look at that, we were doing that long back. Just send the urine in the first trimester for culture and sensitivity, and we are still doing it, but many people have forgotten the simple things. And following any positive culture and treatment, a repeat urine culture must be done subsequently. I think go back to the old system of ruling out urinary infection. Now, the risk assessment is important, which many of the junior doctors are not doing in their clinical practice. It should be done by 12 weeks of pregnancy. When they come for that NT scan, please categorize as risk factor. So when you say high risk factor, it means previous preterm birth or a mid-trimester pregnancy loss, previous preterm labor with rupture of membrane, previous cervical encerclage, or a known uterine variant of uniconnuate, biconnuate, and the uterine septum. And finally, Asherman syndrome. What did they say? If there's a past history of like that, you do one cervical length by even 16 weeks. It may not be 18 weeks. You can call them a little before 16 weeks and check the cervix. Up to 24 weeks, you can do anytime. But you should do by 16 weeks, every 2 weeks, because it's a very problematic kind of a patient. You call her about maximum 4 weeks time. 4 weeks is the time they call, but sometimes you can call earlier if you have a doubt. After 24 weeks, they don't recommend, because most of the time, if it is stable, by then it will be stable. Now, they have said you can also use fetal fibronectin in asymptomatic women, which I'm going to discuss. Now, the intermediate risk is like the previous delivery by cesarean section, full cervical dilatation. I didn't know this initially. We have done so many cases, second stage, prolonged second stage, and subsequently we have always found preterm labor, not always, but a good number. So previous delivery by section at full cervical dilatation is an intermediate risk for the next preterm labor. And of course, anybody having a large loop excision after transformation zone. Now here they said at least start by 18 weeks, up to 22 weeks, at least do once. And they also recommended fibronectin if available. It's not a compulsory thing. So women at intermediate risk should be reassessed at 24 weeks for consideration of transfer back to a low risk pathway. That means after 24 weeks, if it is normal cervical length, you don't go on measuring afterwards. You treat them like any other normal pregnancy. So we can put this high and intermediate risk back into the low risk without any problem after about 24 weeks of pregnancy. So we do not do for everybody walking in the cervical length. If at all you do, just do an anomaly scan. If it is normal, above 3 centimeters, I think it's quite good. 2.5 is low. According to me, it should be 3.5 centimeters. If that is 3.5 centimeter, you do not have to check for cervical length because they don't have problem. So the best practice in the last 2018 published also emphasized on cervical length by transvaginal sonography, and asymptomatic women at risk should be screened at 2 weeks interval from 16 up to 24 weeks. And we know that a low cervical length is a problem. Now, another interesting article in the same best practice I found was the pooled data from these studies suggests that a threshold of 3 centimeters is sensitive to identify almost 70 to 100%. Of course, nothing is 100% in the world. We can say 70 to 100% of symptomatic women who deliver preterm. That means more than 3 centimeters cervical length is 30 millimeters as a negative predictive value of nearly 100% of preterm labors delivery. Thus, it's a very effective method. A threshold of 2 centimeters of cervical length has the best positive predictive value of 70%. So I think we should weigh the balance and check how do we really go about doing things. It's a warning for all of us. We have been doing unnecessarily too many ultrasounds and branding so many people as certain preterm labor just because somebody is diagnosed cervix to be short. I think the measurement has not been taught to several people how to measure. We all should get a training by the fetal medicine expert or at least train yourself. So is the training correct? Who has checked that cervical length? Are we over-diagnosing the short cervix? Are we giving unnecessary treatment? This is a big issue. That is why in UK they made some rules and we have to follow them. Abdominal or vaginal measurement, obviously abdominal measurement can be done, but you know it's not so perfect. We may miss 50% of short cervix. However, filling the bladder significantly also can enlarge the length of the cervix, so it's not too perfect. All the measurements are done by transvaginal ultrasound examination. TVEUE means examination. And it is interesting that the first picture, what is shown here, it is like a T shape. That means there's no internal os bulging at all there. But we also should know a little bit bulge into internal os, less than 25%, is not so significant. So the funnel-shaped appearance of the internal os begins there. A little bit of the V shape there. You have to watch them carefully, but at the moment they are not a problem. But when we know the whole membrane is bulging there, it's sterile. So how do we really measure cervical length? I just want to emphasize a few points because it's a very practical problem. That's why I said I'm not going to talk about preterm labor. Now, look at this. How do we get the internal os? What I put in the red, the endocervical mucosa should be used to define the level of internal os, thereby avoiding confusion with the lower segment of uterus. Sometimes the lower segment is also thinned out and you'll find measuring also goes wrong. So the internal os is measured by the endocervical mucus. External also is measured by the end of it. So it's easy to understand a single point. One more point you watch is this cervix is like a C shape, little bit of C. The C shape is a very good cervix. If the cervix becomes short, it will become straight. A straight cervix is a shortened cervix. Please remember that. So the measurement of cervical length is important. And you magnify, like the NT scan kind of a thing, you magnify the whole cervix to be 75% image. Many people are not doing this and they're not measuring correctly. I have emphasized that several times because I've always find everybody, the junior doctors are diagnosing everybody having cervix to be short. Please take a long time, 3 minutes, because it takes 3 times you must do. Because there can be uterine contractions and the cervical contractions and so on. So the uterine contraction can change the cervix. So we measure 3 times and the average is taken. So the measurement is important to do. From the clinical point of view, the cervix must be always straight. If it is a curved one, sorry, it always must be curved. If it is straight, it is considered as a short cervix. So by abdominal circumference, if you find a very short cervix, less than 3 centimeters abdominally, is a suggestion to do transvaginal sonography because it will be shorter. My experience is somebody says 3 centimeters by abdominal, it will be actually 2 centimeters vaginally. It's about 1 centimeter difference is there. So recheck. That means it's always about 3.5 centimeters. I've had a patient like this. The internal os was closed at 1:55 p.m. Within 2 minutes, I found that it is kind of a V shape in 1:57. 2 minutes later, That means sometimes the dynamic cervix must be watched carefully. The funneling with sludge, if you look at that beyond that yellow marker there, little sludge there, that's a very important sign. If there is sludge at the internal os, that woman will have preterm rupture of membrane. So please consider that point because it is a sign of infection. It's a sign of chorioamnionitis without any symptom. That is, this patient must be watched very carefully. Giving antibiotics or not is our personal decision, but remember that. So the threshold of 2 centimeters to predict latency occurring within 7 days of, that means they may rupture the membrane. That means more than 80% may have a problem when the cervix is 2 centimeter. And of course, it goes on like that. So the role of progesterone is definitely, when the cervix is doubtful, please start prophylactic, either orally or vaginally. Some micronized progesterone can be started. You can start by 16 weeks if you have a doubt. You do not start progesterone for everybody walking in, because that's become a norm in clinical practice in certain places. I do not agree to start progesterone just because they're pregnant. So there is no need to start progesterone unless there is a cervical change. Now, biomarkers. We always thought infection also is a problem. It is true, I agree with that. Some infections which are symptomatic must be treated. Vaginally, you treat that because bacterial vaginosis has been found to be a problem. But we do not do all the other things like interleukin, C-reactive protein. They are all actually markers, but it's not suggested. People can do it like a maybe research and thesis later. However, the fetal fibronectin has come back. It was initially brought in, then it went back. Now it's again people are talking about it. The other ones are not really assessed. We only look at the fetal biomarkers of fetal fibronectin if you have a doubt. Otherwise, we don't really do that. I'm not doing that in my clinical practice because it's right now not freely available. I'm only quoting UK literature. Screening and treatment of asymptomatic women for lower genital tract infection. There is no consistent evidence that the screening and treatment of asymptomatic women improves outcomes. Although treatments are effective at eradicating infection, rates of preterm birth were either no different or increased, not at all increased. That means if they don't have symptoms, you don't have to check. But if they have symptoms, I think you treat it. Simple vaginal infection can be treated by any of these wonderful vaginal tablets. But otherwise, there's no place to routinely check all these kind of patients. Now, suddenly a lot of papers came in saying everybody should go to dental department because periodontal disease can cause preterm labor. It does, but a lot of randomized controlled trials have found they did not find a reduction in the rate of preterm birth even after treatment of periodontal infection. But I think it's good to be careful. Somebody having terrible teeth, I think it's better to do something about that. But there is no need to send everybody for periodontal condition. A little bit about fetal fibronectin. It's a glycoprotein found in between, it's like a glue. It's like a glue between the chorion and the decidua, as I always say that. The last paragraph says, the presence of fetal fibronectin in the vaginal secretion may be seen a few weeks before the actual preterm labor. However, it's not a recommendation at the moment. The risk of birth before 35 weeks increases with increasing fetal fibronectin, that is more than 20 nanogram to 300 nanogram. But what they said is 10, I like the number 10, a lot of 10 in obstetrics. Threshold of 10 nanogram per ml results in higher sensitivity for prediction of preterm labor and when combined with cervical length. But I think above 15 and about 20 definitely significant. 10 is a threshold. The risk was lowest for women with a negative fetal fibronectin and the cervix more than 3.5 centimeters. So when in doubt, cervical more than 3.5, according to me, nothing more need to be done. They do not get into preterm labor. But when in the borderline cases, maybe just to the fetal fibronectin, so more than 20, I think they may get into labor. But I think it's more sensible to put them on progesterone rather than wait for these kind of reports, and so that there is no problem on the later on. Now, they also, one of the other articles in that best practice says, elevated beyond 50 nanogram. That means the value is not yet clear. Is it 10, 20, 50? 50 for sure. 20 you start getting worried about the fetal fibronectin which has come out. So I think the same thing. Now, the importance once again is given to urinary tract infection. The NICE guidelines also says do for all patients asymptomatic urinary infection, because the endotoxins of the urinary organisms can cause preterm problems, because that endotoxin will circulate and cause the uterus to contract, etc. So culture positive samples, even in symptom free, must be taken very seriously. Vaginal infections, in the UK, they're talking like this, but Dr. Piley may comment on that. They are telling about Neisseria, gonorrhea, and chlamydia, but we are not testing for that. They are only testing that because there, I think, STDs are very high, that's what I presume. But this is mentioned in the version 2 of the Saving Babies. They said should be offered, but I'm not sure about India. Dr. Piley, I would like to comment on this at the end of my talk. And bacterial vaginosis is important to understand, but once again, there is no need to check for that for everybody who are not symptomatic. So that's one thing. Now, very interestingly, somebody's had 2 or 3 abortions in the first trimester. They've had some mechanical dilatation done, and suddenly they get into incompetency, insufficiency later on in the middle of the pregnancy. So please remember, done for miscarriage or termination of pregnancy. The good quality studies have demonstrated a small but a significant increase in the risk of spontaneous preterm birth after these procedures, and increases with the number of procedures performed. So don't push the patient away. Somebody has a 3 recurrent pregnancy loss, all the time aborted with some dilatation of the cervix. Then you say, oh God, she's gone beyond 12 weeks, nothing will happen now. You will get a surprise. Suddenly she'll open up the cervix. So I think that patient also must be checked by 16 weeks again, then every 2-3 weeks, at least till 24 weeks, if you want to do. Otherwise, I think it can be alarmed, kind of getting alarmed in these kind of patients, have a little bit of warning signs. Now, interval between pregnancies, a 6,000 analysis of previous preterm birth, those with an interpregnancy interval of less than 6 months had the highest increase in risk of preterm delivery. I think that's important. We also tell after 3 months, 6 months, you can become pregnant. But I think we can delay the next pregnancy for about a year, and or at least after 6 months. So if the pregnancy comes within 6 months, they are somehow delivering again earlier. So probably beyond 6 months is better. The cerclage and its role. We all know cerclage, there are 3 kinds. History indicated cerclage, which I've been talking about. Ultrasound indicated, which I spoke. And of course, rescue cerclage, which cannot be spoken at the moment. I'm not going to talk about it anymore. That's how they divide cerclage. Now, IVF pregnancies conceived at IVF. Initially, I thought they are just like anybody else, but they're all high-risk pregnancies. So there's a 10-fold increase in the age parity adjusted risk of delivery before 37 weeks, and 7-fold increase before 32 weeks in one of the publication. But I've also found, because maybe they're all manipulated cervix by dilatation and so many things have happened, and then they come for IVF. That is just a controversial issue, but there are publications by saying this is another category of patients who may have to be tackled by observation of the cervix much more than low-risk pregnancies. So I've emphasized on the short cervix, and that is a T-shaped cervix the best. Trust your vaginal ultrasound. That's what we teach everybody. That YVU is very bad. If there is no T-shape in the cervix, please get worried about the patient. That other 3 signs are bad. That means they're late. You have missed the bus. And I have found sometimes it's like a moon sign. That membrane would have separated from the internal os. That's another significant point. If you find suddenly one membrane is just kind of detached, that patient may get into rupture membrane. So be careful about it. And the last one is the recent advances of fetal medicine, which is not routinely recommended, elastography. And it is just for research movement at the moment. We are doing in our fetal medicine just for research, but not recommended. If you find these colors, the red color is soft. More the soft cervix, more is the incidence of cervical opening. If you find these red patches are more, that patient has to be more carefully watched. This is just purely research and not as a routine practice. We have been doing it in our fetal medicine unit. Dr. Akila Vasudev is head of the unit there, and she's been doing a little bit of research work, and she was kind enough to give her slides to me. And I realized that this is one of the research which can be taken forward, not in a routine scale, but for research purpose itself. And before I end, I would like to say that the microbial invasion of the amniotic cavity has to be thought about. Any infection which are symptomatic will go up, and definitely there will be a problem in the amniotic cavity. And I will not read the incidents now, but I just want to say there is a possibility that it may get into the bag and the fetus as well. There can be preterm labor if there is infection. Finally, the practice points. The cervical length measured by transvaginal ultrasound is recommended in both symptomatic and high-risk asymptomatic women. Universal screening of cervical length measurement at mid-trimester as a healthy policy needs further evaluation, but there's no harm in doing one. But when decreased length is seen, start predispositions and timely encerclage is a past history. But I think what is not written there is a proper training is very, very important. The senior people must get the training done for the junior doctors, because as I mentioned, how to measure is absolutely not understood by several people. Once again, greetings from Manipal, Academy of Higher Education from Karnataka State. That is our university building, and we have a lovely lake next door. So thank you very much for your invitation and for your patience here. Sir, your audio. Mute your audio, sir.
Prasad, please unmute yourself.
Dr. Pali, sir.
Prasad?
Yes, sir. Yes. Thank you, Pratap. Thank you for this very comprehensive presentation. And I see that Rakhavendra has joined. Please unmute Rakhavendra. If you have any comments, you can come in. Yes, you have covered the topic very comprehensively. I know there's such a vast topic, and you have selected only the risk assessment and prevention for your talk, but even that brings in a lot of practical points. While we are waiting for any questions from the audience, if I may comment on what you asked me to comment, that is about whether screening for gonorrhea and chlamydia is relevant in our setting. Personally, I wouldn't think, because the incidence of Neisseria gonorrhea, at least as we see in the major part of Kerala, is very poor, but very low. But I do admit that there are belts in Kerala where I have been told there are some areas in Kerala, especially on the seaside, seashore areas in some parts of our state, the incidence of Neisseria gonorrhea is very high. And I would probably ask Sangeeta also whether she has any experience about that in area where she is at the moment about. And the seaside areas, some people have told me that the incidence of sexually transmitted disease in some pockets in their areas of practice is very high. But otherwise, I would not recommend it as a routine for a practice in our state.
Yeah.
There are a couple of other things which I want you to comment on, Pratap. You very cleverly did not touch on cerclage, other than saying that the judicious use of cerclage. There's a lot of controversy about it. I don't think time will allow us to go into that. But there is one other confusion happening now because of the age of viability is fluctuating across the world. What should we have the cutoff to count as a preterm labor, between preterm labor and abortion? Should we take, as the WHO and the US suggest, that every pregnancy beyond 20 weeks should be counted as a preterm labor, or whether it should be 22 weeks as the UK seem to suggest, whether it should be 24 weeks, or whether it is 28 weeks as we had been following. And personally, before I finish, let me just put in my suggestion that we should start counting about 20 weeks, but give data separately, 20 to 22, 20 to 24, beyond 24, but certainly for comparison in the Indian setting, we may take at the moment only about 28 weeks. This is what I thought.
Yes, I agree with you totally, because our viability is was defined like that. But I think still age-old 28 weeks seems to be good. But now we are able to survive even 26 weeks of pregnancy. I've had a couple of good results. So I think 26 weeks, we have to definitely try to salvage the baby.
No, we have been able to save even beyond 24 weeks. There's a substantial percentage. So I think what we should do is, rather than delegating all those pregnancies below 24 weeks as abortions, we should start counting them from 20 weeks onwards and put them as extreme preterm like that, and that keep data like that. That is my suggestion.
Correct, sir. 24 weeks also they survive, but I think we are in a gray zone on that area.
Yeah, very true, very true. But now is the time for us to start collecting data.
Yes, sir. Thank you very much.
Be able to say how it is.
So thank you, sir, for supporting. Thank you, sir, for supporting what I said. But I also had a doubt about that particular point which you clarified. Otherwise, I think I was wanted to just tell the junior doctors practical issues about measurements and you know, how to not to overdo things.
Thank you. Raghavendra, you have any?
Yeah, yes, sir.
Can I get some?
Yeah, yes, sir. Yes, sir. One question.
One question is to Pratap sir. Says, what is the role of microbiome in preterm labor, sir? Any role for microbiomes in preterm?
Yeah, I think everything is under microbiome talk these days. And that's what I mentioned, that there is microbiota is the problem of preterm labor. But when there's somebody, we do not test for everybody's microbiome here. Microbiome is there in the vagina, cervix, amniotic cavity. In fact, my last couple of slides did mention that microbial invasion. That is why the microbiota plays a very important role. And if somebody is symptomatic, we have to treat it. I always tell people, like, in fact, I ask them, do you have vaginal discharge? They'll say yes. If they don't say yes, that they say no, then they don't need to be checked for microbiome. I think microbiome plays a very important role in every aspect of our field.
Sir, is high vaginal swab routinely recommended for all pregnant women, sir?
No, in fact, I think swabs are not done for everybody, but people have become routinely to take the high vaginal swab. They're not actually getting any result out of that. In fact, group B streptococcus is one of the problem, which is not at the moment need to be done in India. So I don't think it's necessary at the moment. Otherwise, if you really, because we're anyway going to treat them.
If I may add a point there, Pratap, about group B streptococcus. For a long time, we all were saying that group B streptococcus is not there in India, but for the last nearly 15 years, papers have come out saying that it is there, almost the same incidence as the Western escort. First papers came from Vellore, and we in Kerala also have done some PG thesis and found that group B streptococcus is very much there. And at the moment, our ability to pick them is much better. So those cases where we see expected rapid progression of sepsis and sometimes some babies lost and all that, whether there could be an element of group B streptococcus, because group B streptococcus is there in our women.
Yeah, definitely. It cannot be changed from here to there. It will be there, but as I said, and you also mentioned, maybe now the tests are better to evaluate them. I think it's worth trying that out.
Yeah, I suppose, Raghavendra, are you done with the questions?
Yes, sir.
Paili sir, any observation to make?
No, I just wanted to say one point about what Pratap said about, and quoting the UK statistics, that a cervix below 30 millimeters, almost 100% negative predictive value of preterm labor. I don't know whether to take it like that, especially when we know that serial measurements can show shortening, and that can be significant. And all clinicians will agree that when they have at a 3.5 centimeter cervix measured at the NT scan, and later at 14, 16 weeks, suddenly the women coming with typical presentation of insufficiency. So whether to say 100% negative predictive value is my
no,
only
sir, not 100%. This is not NT scan measurement done at anomaly scan. The 3.5 centimeters is at anomaly scan.
Even there, Pratap, I don't know
not
whether
100%. In fact, I gave that also my opinion. We cannot say nothing is 100%. There's a possibility of sudden shortage, but in a low risk pregnancy, they are finding it's not necessary to check again. But I think it's good to check once in our clinical practice by 26 weeks.
Okay, thank you, Pratap. Thank you for comprehensive coverage.
Yeah, thank you, sir.
I'll leave it to Raghavendra.
Pratap sir, thank you very much for your excellent talk. And not only did you give an excellent talk, but you also had to speak out of turn. Thank you very much for that. Also, you saved the day, not only rescuing the baby, but the program also to some extent. Yes, thank you
Yeah.
very much, sir.
Dr. Sekharan, because I had a problem of internet and Dr. Bhaskar
Yeah.
was not there, I just started. So,
No,
as
thank you very much.
by your request, correct.
It was very nice of you to have done that, sir. And I think I am told close to 1,000 people logged in on a Sunday morning and are listening to whatever you said. I hope they benefited from the interaction. Piley sir and Raghavendra Prasad, thank you very much for having chaired the session. Without much delay, we will proceed to Sekharan sir's talk. Sekharan sir, ready? Sekharan sir, can you unmute yourself? Looks like Sekharan sir is having a bad day in office. Sekharan sir? Do we have Sekharan sir around? Problem again?
No, sir. He lost his connection.
Okay, then
He's not there.
I found him a few minutes back. He was there, but now
Now he's not there.
Like I said, sir is having a bad day in office. Never mind. We'll wait for the time to improve. Bhaskar sir is ready.
Bhaskar sir.
Yeah, Bhaskar sir, are you ready with? I think a few minutes ago itself, sir was ready with his presentation. Sir, can you
Yes, Sekharan is connected.
Please check my slide whether it is visible or
yes, sir. Finally, yes.
Can you check whether my slides are seen?
Not yet.
Not yet. Let me see once again. Now? Okay, thank you. Okay.
Sir, slide share.
Yes.
Yes.
Okay.
Yes, sir.
Welcome back.
Yeah.
Okay, I was just beginning my talk. As we all know that the preeclampsia is one of the leading cause of maternal morbidity and mortality as maternal morbidity. Now, it has been reported that more than 10 million women suffer from this condition world over, and almost 2.5 million preterm births are due to preeclampsia. It has been again reported that over 75,000 mothers and over 500,000 babies are dying due to this condition, which is a preventable condition. Now, preeclampsia is predictable and preventable. So that is the situation now. Now, if you look at our data of CRMD conducted by KFOG, I am quoting the data which we are going to come up with the third edition of our report, that it has shown a maternal mortality from 2010 to 19 of 972 mothers have died during this period, of which the leading cause was obstetric hemorrhage, mainly PPH, constituting about 18% of the total deaths, and 101 women died due to preeclampsia, of which 98 were having preeclampsia, of 56 developed eclampsia and died, and another 42 because of other complications of preeclampsia expired. Of these cases, we can see that there were 30 cases of HELP syndrome in these cases, and cerebral hemorrhage was one of the leading causes of death in these cases, including preeclampsia as well as eclampsia. So this is the background which we have to think about what is happening in our state. And also to note that among these patients, 101 patients, or many were transferred from the primary care center or secondary level to a tertiary care level, and 7 people died on the way before reaching the hospital. That shows that we should have a plan and a policy of referring the cases before they reach the very extreme cases stage. Now, what is the blood pressure of a pregnant woman? This is a publication in circulation by American Heart Association. They have studied the pregnant women before they have become pregnant, during the first trimester, during the second trimester, third trimester, and postpartum. And we could see the blood pressure, average blood pressure of a pregnant woman is around 110/70. And there's a fall in the blood pressure, especially of diastolic pressure at the end of the first trimester, in the second trimester, and late third trimester it may level off. So that is what we have to know. The blood pressure of a mid-pregnancy level is below 110/70 even. And from there, what is hypertension pregnancy? We say pregnant woman is hypertensive when her systolic pressure is equal to or more than 140 systolic and diastolic of BP 90 and above, but which should be confirmed after 4 hours. The blood pressure, when you see that it is very high, say 160 and 110 and above, has to be checked within 15 minutes to initiate the treatment. Now the preeclampsia so far has been very conveniently put it as hypertension with accompanied by significant proteinuria seen after 20 weeks of gestation. We still consider that way, but recently there has been change on this. It has been reported that the proteinuria part is not essential to make a diagnosis of preeclampsia by ACOG by 2013 by their task force, and later on by the International Society for the Study of Hypertension in Pregnancy, which has been approved by the FIGO and other associations. So as per this latest classification or diagnostic point of preeclampsia is, as we said, there should be a blood pressure with any one of the 3 situations, that is proteinuria included. Now, preeclampsia thus can be hypertension with the proteinuria, as we always check, which is diagnosed by dipstick test or 24 hours urine protein, which is not done routinely, or the spot test or protein creatinine ratio of more than 0.3. Both measures are 1 mg/cent. So this is the criteria to say there is proteinuria. Along with or without proteinuria, hypertension with evidence of acute kidney injury as evidenced by a creatinine level of 1.1 mg/dL, liver involvement evidenced by a transaminase increase of more than twice normal, neurological complications, hematological complications like thrombocytopenia, platelet count of less than 100,000, DIC, hemolysis. So a person with hypertension with any one of this factor or end organ involvement is also preeclampsia, even though there may not be any proteinuria, or she may have proteinuria. So that is the second group. And the third group is hypertension with uteroplacental dysfunction. We know that for the hypertension, there are end organs like the brain, liver, kidney, and in pregnancy, the fourth end organ is the uteroplacental unit. So any micro circulation abnormality will be reflected on the placenta by the umbilical artery Doppler study waveform abnormality or the intrauterine growth restriction or stillbirth. So any condition with hypertension which is showing any one of these signs, even with the without proteinuria, is also preeclampsia, as it was. This is the publication which was by the International Society by Study of Hypertension in Pregnancy, published in 2018, which has been accepted FIGO and ACOG and other world organizations. So that is the condition now. Hypertension with or without proteinuria with involvement of any system is also preeclampsia. Now preeclampsia is also classified as early onset preeclampsia where delivery is before 34 weeks, late onset where the delivery is beyond 34 weeks, preterm preeclampsia with the delivery below 37 weeks, and term preeclampsia with the delivery beyond 37 weeks. Now FIGO, ACOG and the International Society do not recommend grouping of preeclampsia into mild and severe variety because as per their conclusion, any mild form of the disease that we consider as mild can become very serious in the later course of the event, and she may suffer from morbidity and mortality even. So that is why you have to be vigilant in any case of preeclampsia. We should also remember that the gestational hypertension may be progressing on to preeclampsia at that time. May not be there is other signs, but they have to be under careful watch because it has been reported that at least 25% of this gestational hypertension if it is developing below in the early, as an early onset, will develop into severe form of the preeclampsia later on. So any hypertension pregnancy, maybe gestational hypertension for the time being, maybe mild preeclampsia for the time being, can progress. That means whenever you see a woman with hypertension, she has to be very carefully monitored. Now, preeclampsia, if not diagnosed and monitored and managed carefully, we know that it can lead on to life-threatening complications like eclampsia, HELP syndrome, DIC, multi-organ disorder, dysfunction syndrome, stroke, abruption for the baby, prematurity, IUGR, and IUD. So these are all part of the complication that can happen in a woman with pregnancy, hypertension, or preeclampsia. Which means blood pressure is one of the most important signs that we have to look for. You know, the preeclampsia is a disease of signs which you have to pick up. By the time they develop symptoms, it may be late and may not be able to prevent the complication. So first and foremost is the measurement of the blood pressure. The patient should be seated comfortably with her back supported, legs not crossing, both arms resting on the table sufficiently high so that when the cuff of the BP apparatus is tied, the center of which will pass through the level of the heart. And she should have been taking 5 minutes of rest in the resting position without talking, without reading, without even looking onto her phone. And you may have to take 2 readings of 1 minute apart and take the average. That is the blood pressure that we have to teach our students and the staff to record it properly. As we are getting rid of our mercury apparatus, we should have the calibrated and automated machines, which may cost 1,500 to 2,500. Even that Omron BP apparatus, which is one of the standard apparatus, may cost around 2,500. And it is worth possessing so that the personal variation of taking the blood pressure may not be there. So it has to be calibrated, and so take the blood pressure during every visit properly and record. We may say that it's a busy OP. Then if it is busy OP, you are going to miss a major complication of pregnancy. So we have to be careful in recording of the blood pressure. We said about the proteinuria. Now, is it possible to predict the preeclampsia? Yes, it is possible. We have to give this opportunity to all the pregnant women, whether they accept or not. In the assessment of preeclampsia prediction, we should have the maternal risk factors like height, weight, BMI, and then any diseases, past history, present history, past after. So all those things we are to take in every case, and that has to be entered onto the software. The mean arterial pressure, you ideally on both hands simultaneously. What especially you have to do is urinary pulsatility index, placental growth factor, and pregnancy associated plasma protein. So all those things can be done along with the aneuploidy screen, which is again to be given to every pregnant woman, offered to every woman. So you do the urinary pulsatility index at the time of NT scan, take the blood for placental growth factor along with the papae that we take for the aneuploidy, measure the MAP correctly, take all the maternal characteristics and medical and obstetric history, and feed on to the Fetal Medicine Foundation software, which is available free of cost. And it's very easy to enter all these factors, and you get a score. If the score is more than 1 in 100, the patient is at the risk of developing preeclampsia. If it is not possible to get the uterine artery pulsatility index or the placental growth factor, at least to take a proper MAP and then add the maternal risk factors. Prediction from the maternal risk factors alone may not be picking up the cases as it is advised by the NICE guideline or the ACOG guideline. They go by the history. You may not pick up the cases, maximum maybe 30% of the possible cases. So to have a better pickup and prediction of preeclampsia, use the Fetal Medicine Foundation algorithm and enter these factors, at least MAP and the maternal characteristics. Once you get the screen positive, whether we can prevent the preeclampsia is the next question. A screen positive of more than a risk of more than 1 in 100 is qualified to get the prophylactic low dose aspirin. Start aspirin in the first trimester itself, if possible, within that 11, 13 weeks or 14 weeks, but not later than 16 weeks. The prevention was not possible in the class study, in the earlier study, which we were all looking for. It was because they started at very later stage of the pregnancy, and that was not a very effective way. And the dose of the aspirin is also important, at least 100 milligram, if not 150 milligram. Given at night is more effective. These are all the study results of various reports. So start the aspirin in the first trimester, not later than 16 weeks. Start an aspirin of 100 milligram at least. Continue up to 36 weeks. You can stop it if you are concerned about the neonatal problem. You can stop by 36 weeks. Thinking that aspirin is such a harmless drug, you should not give it to all pregnant women. We need not give a medication for everybody. It's only about 10% of the people who may be positive for the risk scoring. It is better to supplement calcium also if our calcium intake is less. That is also found to be useful. Now, this is a study result of the ASPIRE trial. It has been seen that 10 to 11% of the screen population may be picked up out as a positive case for preeclampsia development. And the better prediction and prevention was seen in the early onset preeclampsia, which is more dangerous and harmful than the late onset. And they could see that 82% of the preeclampsia could be prevented by the low dose aspirin given at that early time. And the late onset or preterm preeclampsia, which is below 37 weeks, is detected or prevented by 62%. So prediction and prevention of early onset preeclampsia is very much possible up to more than 80%, which is the more dangerous form of the disease, which will result in mortality and morbidity. And there are so many other studies, thousands and thousands of patients are undergoing the trial, and trial results are very encouraging without much of a complications. Now, the hypertension and preeclampsia in albuminuria or proteinuria may not be very characteristic of preeclampsia itself. Hypertension can happen in a pregnant woman due to so many varieties of basic pathology. So now they are looking at whether we can specifically predict preeclampsia or diagnose preeclampsia. In preeclampsia, there is a uteroplacental dysfunction and hypoxia resulting because of the earlier transformation of the spiral artery areoles into the high volume circulation is failing there. And there is a ischemia. And as a result of the ischemia, the anti-angiogenic factors are produced more in quantity. And this will have the maternal effect to have hypertension and other complications. Though their concentration was, they tried to measure the soluble FM like tyrosine kinase 1 and placental growth factor. The placental growth factor is an angiogenic factor, which is favoring the vasculogenesis and the modulation in the placental unit. So when the ratio, that is the soluble FM like tyrosine kinase is going up, the placental growth factor is low, there is going to be vasospasm all over the body and hypertension develops, or other things are triggered. They found that a ratio of SFLT to PLGF of 33 can safely rule out preeclampsia. A ratio of more than 85, that is a placental growth factor is low in a particular situation, we say the patient is having specifically preeclampsia. But presently, the ruling out and ruling in by these angiogenic and anti-angiogenic factors are not considered for clinical practice. So that is the coming up, things are coming up. The another progress that has been made in the research is that the diagnosis of preeclampsia by a simple urine test. Now, Congo red slide test is the one what is being mentioned. In preeclampsia, there is what is known as misfolded proteins, which is nothing but altered proteins because These altered proteins are more in preeclampsia because of the placental protein. I mean, the pregnancy specific proteins are produced in less quantity because of the ischemia of the placental unit, and there will be excess of misfolded or unnatural proteins in the circulation, which will come into the urine. And just a simple slide test like a ready-made test kit is available. You add the urine, drop of urine, which is measured by their pipette, and add on to the test and wait for it. There's a positive and negative control there, and it is specific for preeclampsia diagnosis from 20 weeks to term. So instead of going with the hypertension or proteinuria, which can be there in many other situations, these are some of the specific tests that is coming up. The management, again, I am stressing the point that don't put a mild hypertension and proteinuria as a mild preeclampsia, because it can turn into severe form and lead on to death and other complications. We have to start treating the patient with a hypertension of 140 and 90 and above. Don't wait for further. You have to start treatment. The targeted BP is 135 by 85 millimeters of mercury or less. Whenever you diagnose preeclampsia, you start doing the CBC, renal function, liver function every week, so that you know that your progress of the disease is not missed. You cannot keep on giving some hypotensives and waiting for months together or weeks together, and by the time the disease may progress. The patient who has been diagnosed with a hypertension during pregnancy should have some facility of checking the blood pressure at least every third day. The urine distillation for protein should be done every week. Fetal well-being at the time of diagnosis, and then every 2 weeks when we are allowing the pregnancy to continue. If the patient is having any concern about the safety or any problem, then she has to be admitted and monitored. Any patient who is having a very severe hypertension of 160 by 110 should be admitted and aggressive management for control of the blood pressure, because this may lead on to cerebral hemorrhage, which is one of the very dangerous things and leading to death. Assess the maternal and fetal condition. If the pregnancy is beyond 34 weeks, think of terminating the pregnancy after stabilization of the blood pressure. If it is below 34 weeks, try to pull on the pregnancy with the control of hypertension if it is possible, with a fetal well-being test within normal limits. And below 34 weeks, always give steroid for lung maturity, and below 32 weeks, give magnesium sulfate for neuroprotection. Now, there are very effective drugs which are now available. Even our oral nifedipine, plain nifedipine 10 milligram can act within 5 to 10 minutes. And we can give 3 to 4 doses 45 minutes apart to control the blood pressure if you do not have the IV labetalol. But otherwise, we'll recommend IV labetalol 20 milligram, which will act within 10 to 15 minutes. You may have to repeat it every 15 minutes, starting with the 20 milligram. Maybe another 20 milligram after 15 minutes, not jumping on to 40 milligram. But if not responding, you can have the doubling of the dose every 15 minutes to a desired level of 140 by 90 from 180 by 120. So that is aggressively managing the hypertension. If it is getting controlled, probably you may try to pull on with the pregnancy. Now, indication for termination is without any severe features of preeclampsia. When the completion of 37 weeks, pregnancy has to be terminated even if the blood pressure is controlled, because the disease pathology will be continuing. Uncontrolled blood pressure in spite of using multi-drugs has to be terminated. The other indications are eclampsia, abrasive placenta, fetal demise. You have to terminate the pregnancy irrespective of the term of the pregnancy. HELLP syndrome, don't wait for anything. Probably you may wait for the lung maturity to achieve by giving steroids. Progressive thrombocytopenia, progressively worsening renal and liver function tests are also an indication for termination. Pulmonary edema can develop at any time, which is a serious complication, and the pregnancy has to be terminated along with the aggressive management of pulmonary edema. Progressive neurological symptoms are indication for termination, and on the fetal side, non-reassuring fetal status. When I got management of, dose of magnesium sulfate in threatened preterm eclampsia and eclampsia, should I proceed or stop it here? I can.
Sir, you can take a minute or so more.
I don't know whether I'll complete by that. Anyway, I'll say some of the salient points.
Yes, sir.
I'm giving some tips of managing eclampsia. During a fit, don't try to push in something you can't. You control the patient's condition. You have to keep the airway open, keep the patient in lateral position, give oxygen by mask. Then when the patient is fits are over, then you secure the IV line, take the blood for all investigations. Most important thing here again, I am repeating that if the patient is having severe hypertension, it is not the Maxel that you are trying to push in first, but it is the Labetalol IV to be given, because fit may not kill a patient, but the cerebral hemorrhage will definitely kill the patient. So control the blood pressure immediately, and then think of the loading dose of magnesium sulfate, which easily you can take 4 ampules in 100 ml of one saline bottle and give it slowly, and then add IM another 4 gram, which is the KFOG recommendation. So the loading dose here is 8 milligram, not 4 milligram IV. Then infusion of 1 milligram per hour is given as a drip of 4 ampule added on to 100 ml. Give 25 ml per hour. You can use the infusion pump, and if there is any toxicity, you should have the calcium gluconate. Pulmonary edema is a complication of eclampsia and preeclampsia. Restrict the fluid to 60 to 80 ml. I think I'll stop here. Maxwell is 1 gram per hour.
Gracie ma'am, I request you to conclude the session with thanks.
Hello?
And, yeah. Please unmute yourself, Gracie ma'am.
Hello?
Please
Can you
unmute
hear?
yourself. Gracie ma'am, please unmute yourself.
Can you hear me?
Yeah.
I'm Dr. Shamla. Can you
Yeah,
hear
ma'am.
me?
Madam,
Yeah,
please
yes.
go ahead.
Okay. I have the same trouble with Dr. Sekharan because he said we are friends and sisters, sister and brother. So problem with the technical problems. I think it was a very good crisp and elaborate presentation of preeclampsia. You have covered almost all points, Sekharan. But I just wanted to about atypical preeclampsia also. So many of the patients, we don't see all the signs and symptoms. They may come with atypical features, and also de novo postpartum hypertension. We have seen cases, even maternal death, where the patients are non-hypertensive till delivery, and they come in the first postpartum period with hypertension, eclampsia, help, all these things. So I think that also has to be included in this.
Very
Okay.
true, madam. Very true.
Okay.
Patient who has been treated with hypertension after delivery has to have the blood pressure monitored every 4th hourly for 24 hours, 6th hourly, and then for at least for 72 hours, if not 6 days. Up to 6 days postpartum, the BP can rise, which was not so in the pre-antenatal period, can become severe and can have a fit beyond that.
I think
Defined
not,
and it
okay.
Okay.
Okay,
May not be
Sharon.
signs of
Not all the patients are preeclampsia. A patient who has normotency throughout pregnancy, for the first time she may develop hypertension in the postpartum bed, de novo hypertension. That also, now we always ask the patients to take the BP in the postnatal period on. Okay. Then atypical presentation. Some patients may only have overweight, massive edema, overweight, ascites, or that is capillary syndrome without any symptoms, without any BP, normal BP like that. So that patient has to be closely followed up because abnormal weight gain, that also we may miss. When the patient comes with eclampsia only, we will diagnose it as a case of preeclampsia. That is a good thing. Then, as you said, the SFLT placenta growth factor ratio is very, very important to diagnose preeclampsia, especially when it comes as the mirror syndrome. Because there are conditions which may imitate preeclampsia. We don't know whether to induce the patient or whether to continue with pregnancy, like parvovirus, non-immune hydrops, etc., etc. So that SFLT placenta factor is very helpful in that condition to differentiate the mirror syndrome from preeclampsia. It is a very good narrative. No other questions I got?
Piley sir has
sir.
put a question. Would you limit steroids for lung maturity to 34 weeks? Because you said that.
Now, beyond that, it's not necessary to give, because it has been reported later on now that the steroids given may produce some neurological problem. We were thinking that it's all safe and innocuous, but it has been reported that unnecessary you should not give. By 34 weeks, the fetus are mature. Even the doing elective cesarean up to 38 weeks, they say that you can give one dose of one course of the. But later on, problem of the prematurity due to lung immaturity is over by 34 weeks. So they recommend now to avoid the late complications in a newborn or in a child. They have seen that the child brain can prevent the excess of corticosteroid which is released during labor due to the stress. But the steroid that we are given is not metabolized by the enzymes of the newborn's brain. That is where there can be long-standing neuropsychiatric developmental problems. So because of that knowledge, I think we should limit to 34 weeks. And even if you give steroid, only 50 to 60% RDS can be prevented. But if you give the steroid, the surfactant given later on in the neonatal period will be more effective. So there is every place for steroid to be given for preterm labor, but not beyond 34 weeks because of the concerns of the neuropsychiatric development that has been reported nowadays. That is the thing.
Gracie ma'am, any questions or observations to make? Gracie madam?
To add to what Dr. Sekharan has said, now they say that after 34 weeks, the problem is actually the TTN, tachypnea of the newborn. So that doesn't need steroid to cover. So it is better not to give after 34 weeks because of the neurological problems.
Gracie madam, anything to mention or state? Gracie Thomas madam?
No, I think there were a lot of Professor Sekharan. It was a very nice and clear, simple, clear talk. And there were a lot of take-home messages. Especially you have explained the prediction and prevention so that we won't end up in complications. And you have conveyed the message, how to be vigilant always, even with mild preeclampsia. And I think most of the doubts in the participants will be cleared. With the
Sekharan sir, one question from the audience. 140/90 BP labetalol was started, and then the BP became 130/80. Now should the labetalol be stopped?
Not to be stopped. Not to be stopped. You have to continue with the antihypertensive therapy. Not to be stopped.
Yeah, I think that. And glycosylated fibronectin, sir. One more question from the audience. So I'm asking you. Glycosylated fibronectin, role of that in this.
Thank you very much.
Yeah.
Prediction.
Yes,
I have seen it, but not still in research field, because whatever said, I said also is on the research field, some of the things like Congo Red and all. But the clinical use has been come.
Yes.
Even the Perklin Elmer has produced this kit, that Congo Red, Congophilia. So it is all coming onto the clinical practice also. We may, next year probably, we may also be doing all those things. So it is all in the field. Okay.
Can I just bring in one point actually about that steroid? Is the RCOG still recommending for elective cesarean up to 39 weeks to give another additional dose of steroid? That's the first thing. And second thing, Sekharan, would you like to comment on everybody starting on labetalol as the first line antihypertensive? I would say that
probably
that should not be the case because labetalol has a beta blocker effect.
Yeah. If possible, we were all happy with the M-DOPA group or L-DOPA, M-DOPA, whatever it was, not available. So people are switching over to the next two drugs. You can think of nifedipine retard form can be used in the mild form initially, because a long-term use of the labetalol in the antenatal period can produce even IUGR for the baby. So, and also neonatal period, hypoglycemia and all those things were reported. So probably, since we are not having the option of methyl DOPA group of drugs, probably we may have to depend upon. So you may suggest, I think your recommendation is to start nifedipine instead of labetalol for a long-term use is also possible. The second question, I know that even up to 38, 39 weeks, one shot of steroid, if it is an elective cesarean, is still there in the some of the guidelines. But
they are not recommended.
These things, why should we give? And because of the potential, because nobody has tried a long-term effect of the steroid given to the in the antenatal period to the babies. And now they are coming with the report even up to 18 years follow-up or other things on the newborn babies who were exposed to the corticosteroid. And their theory is that when you give this steroid, it is not destroyed by the placental enzyme. The enzyme is 11-beta hydroxy dehydrogenase to be a 2. That is the enzyme. So this is not going to hydrolyze the excess circulating DEXA or betamethasone which we are giving. And this concern has been expressed. So that is where the question of stopping it. And also the repeated dosing, we know that we don't give. Even the rescue dose is being questioned. The patient has received corticosteroid below 28 weeks. Now she has gone to 32 weeks. She may deliver in the next week probably. The rescue dose was recommended. Now that is whether we should give, because the lasting effect of the corticosteroid may not last up to 34 weeks if you give to 28 weeks or 30 weeks. So that was the rationale for giving a rescue dosing in preterm delivery. So these are all now being questioned because of some effect or bad effect on the neuropsychiatric development of the babies or the children. So that is where we have to have a balance. We have to protect the babies from dying from hyaline membrane disease, which is possible to prevent in 50 to 60% if you give up to 34 weeks. Beyond 34 weeks, hyaline membrane disease is not the major cause. It may not kill the baby, but it can have some problems, but that's why it is being limited. There are so many articles which has come onto the late effect of the corticosteroid. So we are advised to give even single dosing, that is the 2 doses. That to the salt is to be now being questioned. Which salt has to be given, whether DEXA or betamethasone. So these are so many things are there in the corticosteroid therapy. But sir, to save a baby, we may do anything at our hand for the time being. And that is where we may give up to 38 weeks, or as it is given in one of the major guidelines, we may continue to give. But the concerns I express, and that's the reason for limiting it to 34 completed weeks, below which you can give, beyond we need not.
Sir, in keeping with the flow of the session, sir, I shall wind up the session with your permission. Excellent talk, sir. Thank you very much, Sekharan sir, for that wonderful talk. There are a lot more questions, which, I think this talk was so important that it requires a full longer session. But however, you did justice. And thank you very much. And thank you, Shamala madam and Gracie madam, for having chaired the session. Now we will move forward with the next session. But before I move forward, a lot of people have logged in. I once again want to apologize for the change in order of the presentation of the program. That is due to some technical difficulties beyond our control, and also to Pratap Kumar sir, who had to change his order of presentation, and a lot of delegates had some difficulty in logging in initially. So our sincere apologies on both these counts. Now I go ahead with the next session. I invite Bhaskar Pal sir to give his presentation, and I call upon Beena Kumari madam and Dr. Shaijas to take over as moderators for this session. Beena Kumari madam, of course, senior member of KFOG, additional professor and head of unit at Kottayam Medical College, and Shaijas, our ever dynamic and colorful president of the Kannur ONG Society. And over to you, Shaijas and Beena Kumari madam, to conduct the session.
Good morning, dear senior colleagues and friends. Now, after initial hurdles, now the KFOG CME is going smoothly. Now we are going for the next talk by Dr. Bhaskar Pal. And Dr. Bhaskar Pal is a senior consultant gynecologist at Apollo Hospital, Kolkata. He's an honorary Secretary General of IAG and Chair of AICC, RCOG Zone, and FOXY representative to SAFOG 2021 to 23. He will be talking upon a very important and embarrassing problem of both the gynecologists and the patients regarding endometriosis. Over to you, sir.
Thank you. Thank you for the kind invitation and the introduction. And Ambuja madam has focused my topic very nicely: scope and options for medical management. So what I would do is I would first look at the options for medical management, then look at the scope for medical management, and then would like to try and match those two. Just to set the context, endometriosis affects up to 10% women, and 50% of women with dysmenorrhea will have endometriosis. In 3/4 of women with pelvic pain, there will be endometriosis. And in approximately 1/3 of women with fertility, there will be endometriosis. There are three problems with endometriosis. Number one, it is shrouded in controversy. Number two, the outcome is often unsatisfactory. And third is the issue of recurrence. And that is why I guess Dr. Bina Kumari said that this is embarrassing to the doctor as well. Now, our aim of endometriosis management are essentially three. Complete resolution is not usually possible. So our aim, depending on what the patient presents with and what she wants, would be to reduce pain, to increase the possibility of pregnancy, and to delay the recurrence for as long as possible. And it could be more than one of these. So in scope of medical management, what I would look at would be pelvic pain with a normal ultrasound, endometrioma, both asymptomatic and symptomatic. Is there any role in pre and post-operative usage? What is the role of medical management in infertility? What is the role of medical management in deep infiltrating endometriosis? And what is the role of medical management in recurrence? And what are the options of medical management? It starts with NSAIDs as pain relief, COC pills which have been used for long, progesterones in different form. It could be oral, intramuscular, the intrauterine cyst, levonorgestrel intrauterine system, or even progesterone only pills. I would like to cover Dynogest as a separate one, and a lot of focus on this talk would be on Dynogest, because that is what I think has radically changed the medical management and the management of endometriosis. We would look at GnRH analogs, we'll look at aromatase inhibitors. We would not look at danazol, because I think that is a drug which now should be relegated to the museum, especially since we have better drugs available. And also we will just touch the issues of cabergoline and rosiglitazone. What about COC? COC is limited evidence whether it has any effect on the progression of the disease, but it has been widely used due to contraceptive protection, long-term safety, and the control of menstrual cycle, and especially cost. It does reduce endometriosis-associated dysmenorrhea, dyspareunia, and non-menstrual pain. If it is endometriosis, then very often we would prefer to use a continuous usage rather than using it on a 21/7 regimen. So there are two ways of using it. Number one, that you tricycle it, use 3 to 4 packets and then give a 7-day break, or you don't give any break at all. You just continue it continuously, and whenever the patient has a breakthrough bleeding, give a 7-day break. We may use the vaginal ring or transdermal patch. Unfortunately, the vaginal ring is no longer available in India, but it had excellent results. Progesterones in different form. We could use medroxyprogesterone acetate as an oral or a depot preparation. All reduce endometriosis-associated pain. There is evidence that LNG-IUS reduces endometriosis-associated pain. GnRH for long has been a very important part of endometriosis management. They reduce endometriosis-associated pain, but there is limited evidence regarding duration of use and dosage. Essentially, the problem is that it has been essentially licensed for 6 months of usage. But if we want to use it for longer period, we need to use hormonal add-back therapy to prevent bone loss and hypoestrogenic symptoms, and it can be started as soon as the GnRH analog is started. There are studies which looked at usage of GnRH analog with hormone add-back for up to 2 years. The add-back does not affect pain relief. There is no significant evidence as yet on GnRH antagonists. We need to use GnRH analogs with caution in adolescents and young women who still not achieve their peak bone mass. What about aromatase inhibitors? They cause remission of pain and reduction in visible endometriotic lesions. As with other medical therapies, symptoms do recur soon after the treatment is discontinued. There are problems like mild headache, joint stiffness or pain, nausea, diarrhea. The hot flushes are milder and less frequent than GnRH analog. But one of the most important issues with aromatase inhibitors is breakthrough bleeding, and also on long-term usage, they can cause osteopenia and osteoporosis. What about cabergoline? Cabergoline has been in focus because of its anti-angiogenic properties in a dosage of 0.5 milligram twice weekly for 12 weeks. There is one study, one randomized control trial, which showed reduction in the volume of endometrioma with 12 weeks of cabergoline. This was published in 2014. There is a study ongoing at All India Institute and it is yet to be published, but the results are very encouraging. So please watch this space for cabergoline. What about Dynogest? We all know, I will not go into the pharmacology of Dynogest, but we all know that we've heard that enough. I think it has been, we have enough of talks on Dynogest for the last 3 years or so. But it is an oral agent which is used in dose of 2 milligram per day. There is no benefit of increasing the dose. In fact, there is a study which looked at 2 milligram versus 4 milligram per day, and there is absolutely no benefit. It has a high bioavailability, but what is important about Dynogest is that it is one of the few drugs which has a potent inhibitory activity on the growth of endometrial tissue. Also, it has an anti-angiogenic and anti-inflammatory effect. The initial studies came from 2 clinical programs in Europe and Japan, where it is used for 6 months, and there was effective alleviation of painful symptoms, improved quality of life with a very favorable safety and tolerability profile, high compliance rate, and low withdrawal rate. Subsequently, there were 4 RCTs in Europe, and the European studies laparoscopically demonstrated reduction of deposits in grade 2, grade 3, and grade 4 disease. Direct comparative study with GnRH analog showed a comparable pain improvement in visual analog score. There was a non-randomized study of 12-month use which showed significant reduction in dyspareunia and non-menstrual pelvic pain and comparable result to GnRH agonist followed by Dynogest. Now, please remember that Dynogest effectively suppresses ovulation at 2 milligram per day, but it is not a contraceptive. So non-hormonal contraception should be advised if the patient is not planning pregnancy. But if the patient gets pregnant, there is no need to offer a termination because it has no teratogenic effects. It is an acceptable agent for monotherapy, and it is approved as a monotherapy agent in many countries. Like all progesterones, the problems are similar. The problems are with initial bleeding irregularities, but the intensity and frequency reduces on continued treatment. But in some patients, it becomes a problem managing the initial bleeding irregularities. The other side effects are all progesterone related, like headache, constipation, breast discomfort, depressed mood, and acne, which will happen in 5 to 10% of women. A very important question that keeps coming up with Dynogest is how long can we use Dynogest? The first long-term usage came with a 52-week study for adenomyosis, and thereafter several studies came on usage for 12 months. The first long-term study came in 2017 when it was used for up to 48 months following laparoscopy for DIE to prevent recurrence. And in 2019, the 60-month review of efficacy and safety was looked at in a group of 37 women, and it was shown that up to 60 months, there was no worries about its safety profile. Now, before I get into the scope of medical management, I think there is a time has come to question the basics. And it is not only based, it is just a question of based on anecdotes, it is based on evidence, it is based on the latest guideline of ASHRAE. Now, what were we taught? We were taught that the gold standard to diagnose endometriosis is a laparoscopy. So you do a diagnostic laparoscopy to diagnose endometriosis. The second thing we were taught that any endometrium, any ovarian endometrial cyst, which is more than 3 centimeters and is symptomatic, should be operated. We were taught that recurrence is common and it is not uncommon for a woman to require multiple surgeries in her lifetime. We were worried that all endometrioma before IVF should be operated because there is a risk of the endometriotic fluid contaminating the follicular contents and causing a problem with the clinical pregnancy. The entire basis of endometriosis management has changed. Now we should not be in a rush to put in a laparoscope to diagnose. Essential diagnosis of endometriosis will be clinical and by imaging. And I would actually stick my neck out and say that there is an operation called diagnostic laparoscopy possibly should be banned or abandoned. Any laparoscopy where we find endometriosis should be treated, and a patient with chronic pelvic pain should be counseled to that effect. And a laparoscopy for such patients should not be done by somebody who cannot treat endometriosis at the same sitting, which means a see and treat approach. But we should delay the first laparoscopy for as long as possible. Endometriomas can be managed medically even if they have pain, irrespective of the size if the patient so desires. In her lifetime, we would like to minimize the number of surgeries to as few as possible and make sure that the first surgery is her best opportunity and that is done by somebody who's skilled at it. And most endometrioma do not need operation before IVF because the contamination doesn't affect the clinical pregnancy rate. The only indication for operating an endometrioma before IVF would be if the infertility specialist says that he or she has problems accessing the ovary to get follicles. So if there is a pelvic pain or dysmenorrhea, what can we use? We can start an empirical treatment. Obviously, analgesics would be the first line, but they are not very useful in managing it if it is endometriosis. We can use COC pills, we can use progestrogens, we can use Dynogest as well. But please remember, especially in adolescents with the Vesado study, there is a small loss in bone density with Dynogest. So we need to be slightly careful when we're using Dynogest in adolescents. If we are using in elderly women who are happy to have an LNG IUS, we can even consider an LNG IUS. If empirical treatment fails, we can consider a laparoscopy. If empirical treatment is successful, we do not need to put any arbitrary timeline on how long we would keep the patient on empirical treatment. The answer would be as long as it is safe and as long as the patient is responding. The RCOG guideline also says that you can use you can treat pain symptoms without a definitive diagnosis, and so does the SOGC say. And they all say that your first line treatment for these would be the combined oral contraceptives or progestrogens. And NSAID can be used as an adjunct, but it is very poor used as a monotherapy for pain. If there is an asymptomatic endometrioma, I think it is very important to confirm the diagnosis. A lot of radiologists mix up between an endometrioma and an hemorrhagic cyst, and they have completely different sonological characteristics. Even if you find an asymptomatic endometrioma, a short expectant management is acceptable, which means not do anything for 6 weeks to 12 weeks and repeat the sonography to see if it is there. If the cyst persists, we need to counsel the woman about the effect of endometriosis on fertility without trying to influence her outcome. If the patient wants to, knowing everything about endometriosis and infertility, if the patient wants to defer childbearing, then absolutely we need to go with that decision. And of course, we need to give them an option of social freezing. Can these be managed medically? Yes, they can be managed. We can manage very small endometrioma with the oral contraceptive pill, moderate side endometrioma with Dynogest, and my personal preference is to manage large endometrioma initially with GnRH analogs and then move on to either Dynogest or to the combined oral contraceptive pill, because there's no very good data on Dynogest and oral contraceptive pills with large endometrioma. Same with symptomatic endometrioma, we should counsel them about effect on fertility. For symptomatic endometrioma, I would straight away go on to either Dynogest or the GnRH analogs to start with. And as I said that my large endometrioma, I would start them on GnRH analogs, smaller ones on Dynogest. Pills essentially for asymptomatic women or patients who cannot afford Dynogest or GnRH analogs. Now, the question has always been whether Dynogest is effective with endometriotic cysts. 2 studies have come out in the year 2020, and it shows that with smaller endometriotic cysts, Dynogest is effective. The first one is a prospective trial, and it had 32 women with cyst diameters of 4 plus minus 1.3 centimeters. And they showed with 6 months Dynogest, there was a 40% reduction in diameter and 80% reduction in volume of endometrioma. If we go back to our physics or maths days, you know, the volume is calculated as pi r cube, where r is diameter by 2. So obviously, when you see a reduction in diameter percentage-wise, please remember the volume reduction has been much higher. The other study, which has been just published a couple of months back, was in 116 women. And these women were put into 3 groups, one group with or no medication, one group on Dynogest, and one group on ethinyl estradiol Dynogest pill. And these women had a mean cyst diameter of 23 millimeters. And with 12 months of therapy, in the Dynogest group, 76% of the cysts disappeared. In the Dynogest containing pill group, 40% of cysts disappeared. And in no treatment group, 4% cysts disappeared. So in smaller endometrioma, Dynogest alone is a good enough medication to be used. Now, what about pre and post-operative therapy? Preoperative hormone therapy improves revised American Fertility Society scores, but essentially has very little effect clinically. So very few people would use any preoperative hormone therapy. The RCOG guideline says that there is insufficient evidence of benefit to justify use of postoperative hormonal treatment, but the problem is that this guideline is 2010 and a lot of things have changed after that. And if you look at the ASHRAE guideline, the ASHRAE guideline does talk about a postoperative treatment. And earlier ASHRAE guidelines spoke about treatment with danazol or GnRH agonist. And also it said that the post-op treatment with the COC is not effective, but we use a lot of COCs, especially because of financial reasons. Now, what about GnRH? Treatment for 3 months with a GnRH may be as effective as 6 months in terms of pain relief. Treatment up to 2 years with combined EP add-back appears to be effective and safe, but careful consideration should be given to the use of GnRH analog in women who may not have reached their maximum bone density, and that means adolescents. Now, can GnRH and Dynogest, are they equally effective? And this is a study which looked at post-laparoscopy Dynogest 2 milligram per day for 6 months or monthly goserelin for 6 injections. And recurrence rates and symptom relief were similar in both the treatment groups, and there were less side effects in Dynogest group, and that is essentially because also Dynogest creates hypoestrogenic state, that hypoestrogenic at the lower levels of physiological levels, so you do not get much menopausal symptoms with them. Dynogest versus leupride, equally effective in reducing symptoms of dysmenorrhea, dyspareunia, and pelvic pain. Minimal change in BMD with Dynogest, and there are no hot flushes. In postoperative treatment, we have a lot of time. We've spoken about adjuvant treatment, giving the patient 6 months of pill, giving the patient 6 months of 3 to 6 months of GnRH analogs. But what I really want to talk about the scope of medical management is secondary prevention. Secondary prevention is a long-term postoperative hormone treatment up to 2 years or maybe longer in an attempt to reduce recurrence in somebody who's not desirous of children. And secondary prevention can be done with COCP, can be done with LNG-IUS, can be done with Dynogest. And LNG-IUS inserted at laparoscopy may reduce the risk of recurrence of dysmenorrhea. As with Dynogest and GnRH in both, the beneficial effect of the pain exceeds the period of treatment, which means that what happens is that the recurrence of symptoms appear to be lower with Dynogest, appear to be delayed with Dynogest and GnRH analog compared to other agents. Dynogest with estradiol valeriate is comparable to GnRH analog in reducing the recurrence of pain following laparoscopy, but that pill is not available in India. What is the role of medical management of infertility? Treatment with GnRH analogs for 3 to 6 months before IVF in women with endometriosis increases the rate of clinical pregnancy rate. Other than, I would like to say, there is no role of medical treatment in infertility, and please do not waste your time and the patient's time in trying to do so. There is an isolated paper which was published in 2015 which showed Dynogest improves IVF success rate in women with adenomyosis and IVF failures. But if then there is a early 2020 paper which shows that pre-IVF Dynogest actually reduces the clinical pregnancy rate in women with endometriosis. So at the present moment, the only role of medical treatment in infertility is pre-IVF GnRH analogs. What can you use if deep infiltrating endometriosis? GnRH analog have been used, aromatase inhibitors have been used, and both of them have shown a decrease in the size of nodule, whereas LNG-IUS and Dynogest have been used for symptom relief with no change in the size of the nodule. And these are the aromatase inhibitors that are used, essentially letrozole 2.5 milligram per day or anastrozole 1 milligram per day, and usually they should be used along with a combined oral contraceptive pill to improve the bleeding profile as well as to decrease the effect on the bones. Now, Dynogest has been used in retrovaginal endometriosis. It's a 24-week study which showed an improved quality of life, decreased pain, and improved sexual life. There is a 12-month study which showed effective in reducing pain in DIE, but there was no reduction in volume of the nodule. I am just not going to go through this slide, but we have come to the last part of the talk, which is recurrent endometriosis. And you can see from the data, recurrence is a big problem. And I tell my patients that the only thing that is guaranteed in the treatment of endometriosis is the recurrence. So irrespective of who treats you, so anybody who doesn't talk to you about recurrence is not being honest with you. And you look at recurrence risk increases with the period of follow-up. What are the risk factors for recurrence? The severity of the disease, the extent of surgical excision, and the younger the age, obviously the more would be the risk of recurrence. Pregnancy and post-operative adjuvant treatment are protective and in the sense that delay recurrence. In recurrence, medical management should always be the first line of treatment. And what can we use for medical management? We can use Dynogest. It has the benefit it can be used long-term. We can use a short-term GnRH analog if the symptoms are very severe. We can use LNG-IUS and COCP, or we can use DMPA, and all of this can be used for long-term. If there is recurrence with infertility, ART should be the first line. In recurrence, Dynogest can be used long-term, and GnRH agonist, as I said earlier, can be used long-term along with adequate add-back therapy. The add-back therapy should be started right from starting the first GnRH analog. And this is from the SOGC 2010 as well, and up to 2 years is well documented. So the take-home messages are the role of medical management in endometriosis is limited, but it is increasing. All agents are equally effective or ineffective for pain relief, but they differ in their safety profile and in terms of their side effect. LNG-IUS is effective for post-operative pain relief. Post-operative GnRH analog, danazol, delay recurrence and reduces pain. Having said that, adverse events limit the use of danazol. Dynogest is an effective option for medical management as first line and post-operative and has the potential for long-term use. But most importantly, treatment of endometriosis needs to be individualized, and a judicious combination of surgical and medical treatment is the best option in most situations. Thank you very much.
Thank you, sir. That was a very elaborate talk on medical management of endometriosis. We'll take a few questions.
Before that, Bhaskar sir, really appreciate your clarity of thought and that authoritative manner in which you always puts across your point, but yet a very, very balanced approach. And the punch dialogue, the only thing that is certain is recurrence. And I think these kind of statements can really help us because once there is recurrence, even after a surgery, when she comes for a review and you find that there is some cystic element that still persists, this punch dialogue that you have delivered earlier might be the saving point for you. So that was such an important thing that you told, sir. Beena madam, go on.
No, you can take up the questions.
Madam, I can see a question from Dr. Piley in the chat box. And he's asked whether OC pills, whether we'll recommend a 21-day cycle or an 84-day cycle. In endometriosis, we would never recommend a 21-day cycle, sir. There are two ways of the evidence is very clear that the pain relief is much better if we use it for longer periods of time. So yes, either we should use it for 63 or 84 days and then give a break, or the other way, sir, is to not give a break. And that the Faculty of Reproductive and Sexual Health guideline is that you keep the patient on continuous pill. The moment they have a breakthrough bleeding, you give a 4 to 7 day break and start again.
How long will you give a continuous OC pill, sir?
As long as she doesn't have a breakthrough bleeding, madam. But in reality, most patients would have a breakthrough bleeding within 3 months.
Okay. Bhaskar sir, a question from the audience. What should we continue the pregnancy? Can we continue the pregnancy when they become pregnant while on Dynogest?
Yes, absolutely we can. And last week I delivered somebody who was on Dynogest and didn't even realize she had got pregnant. I use Dynogest a lot, and this is a patient who never told us that she wants to get pregnant. So one fine day in her amenorrhea, she felt nauseous and we found she was pregnant. No, there is absolutely no indication to terminate the pregnancy, provided the patient is happy to continue.
Thank you,
Another
sir.
question is, in symptomatic adolescent girls, what would be the drug of choice?
I would go by the age, madam, but in symptomatic adolescent girls, I would always combined oral contraceptive pill would be my first choice. Unless if the combined oral contraceptive pill fails, I would have to put on, I will try her on Dynogest. The reason with the oral contraceptive pill is that we know a lot about the oral contraceptive pill. And that is one of the few drugs where we are assured about its safety, about its adverse effects. And there is no adverse effect as far as on the bone density is concerned. Elderly adolescents who's gone up to say 17, 18, I wouldn't mind putting them on Dynogest if the oral contraceptive fails. I would be very, very cautious about putting 14, 15-year-old girls on Dynogest because there is evidence that it does cause a bit of reduction in the bone density. The other cause is a question that often comes up that if we can use Dynogest, why can't you use a Dynogest containing pill now that we have one in the market? The one which is extensively studied is the Dynogest estradiol valurate pill, which is still not available in India. In India, we have the ethinyl estradiol Dynogest pill. The issue is that the evidence is that you can use that Dynogest containing pill as a substitute for a pill, not as a substitute for Dynogest. because we do not know whether that addition of estrogen, what effect it will have on the biologic effect of endometriosis. So it is logical, if you are using a combined contraceptive pill, maybe go for the one with Dynogest as a substitute for the pill, not as a substitute for Dynogest. So again, to come back to your question, adolescent, my first line would be oral contraceptive pill.
Okay. So just a point. Okay. Yeah, just a point. People are using the combination of ethinyl estradiol and Dynogest pill, thinking that Dynogest alone would cause irregular bleeding or may end up take up the patient into amenorrhea. But this combination might give them regular menstrual cycles at a time when they require. So does that make any sense, using that pill in a patient where you have some amount of endometriosis inside?
No, it depends on, as I said again, I would use Dynogest containing pill when I'm considering using a pill. I will not consider using that when I'm considering Dynogest. There's a question from Dr. Vinay Chandran about sir about DMPA, and I think DMPA is a very, very useful molecule. And the only problem with DMPAs are two. There are only two problems. Number one, among all the progesterone, it causes the maximum amount of irregular bleeding. And number two, the delay to when the patient gets amenorrheic, the delay to onset of menses is much longer. So DMPA is a very, very useful alternative for long-term treatment of endometriosis in women who completed their family. I wouldn't like to put a patient who's still not planning, who's yet to decide on her family on DMPA. But it is a very effective drug. The only thing we need to be worried about is the bone loss. So again, we need to be careful in women above 45 and girls under 18. But I reserve DMPA for women who require contraception and who've completed their family and have got endometriosis.
Bhaskar sir, one question from me. Which is that drug to save the situation when you end up with a cystic lesion immediately post-operatively? Though we understand that a routine post-operative treatment for endometriosis after a surgery is not recommended.
Unfortunately, Shizers, there is no way to predict that which patient, the problem is we do not understand endometriosis that well, and all endometriosis are not the same. We do the same surgery, we give them the same post-operative treatment, even then some of them, very few of them, but some of them do end up with an early recurrence. I think early recurrence, I think you need to, given the point of patient compliance, you need to have something which will work soon before the patient starts getting jittery. So GnRH analogs are more useful than Dynogest in a quick resolution of an endometriotic cyst. So as I said, I always choose GnRH analog if it is an acute situation or if it is a large cyst.
What is the ideal add-back therapy, sir, do you use for, along with the GnRH analogs? Because otherwise you cannot use it more than 6 months, no?
That's right. 6 months, that too in a lifetime. I actually, when I start patients on, the problem is, the other problem we have in post-operative adjuvant data, most of the data that comes is from 6 months, whereas most of us give it for 3 months and then leave.
Right.
So ideally, we should give it either right from the start when you use it or maybe from the second injection. I use estrogen only, provided I'm using it for 6 months. Some people are either of the idea that with Tibolone, there will be less activation of endometriosis. Unfortunately, there is absolutely no data to say that Tibolone causes less aggravation of endometriosis compared to estrogen. So it is either estrogen or you can use a estrogen progesterone pill also, but I use estradiol validate 1 milligram per day as an add-back therapy.
Okay.
Sir, Shaijes and Beena Kumari madam, with your permission, shall we wind up this session in keeping with the flow of the program? Bhaskar sir, thank you very much for that wonderful talk on enigmatic endometriosis, as they say. Everyone is raising their hand in applause, and there are so many more questions because it's such a topic of practical relevance, and you have dealt with a lot of messages, Bhaskar sir.
Thank you for the invitation.
Yeah,
always a pleasure to be here.
Shaijes and Beena Kumari madam, thank you very much for making this session.
Thank you, Venu, and thank you, Ambuja madam.
Yeah. So we shall, without delay, proceed to the further session, which is on ultrasound, and I hand over the stage in the next hour to Ambuja madam to conduct this session. Ambuja madam, all yours. And along with Ambuja madam, I invite the co-moderators, Dr. Sangeeta, Dr. Lalitambika, and Dr. Jyoti Ramesh Chandran. Ambuja madam, all yours for the next hour, without disturbance from any of us.
So we are starting the ultrasound session. We have two eminent speakers. To start with, we have Indrani Suresh madam. She is going to talk on ultrasound detection in the second trimester and way forward. I am very happy to introduce Madam Indrani Suresh. She is the Director of Fetal Medicine Unit, Mediscan. She is a pediatrician by training, but a zoologist by choice. And I'm sure all of you know that she is the wife of Professor S. Suresh. And both of them have great passion for fetal medicine, and actually they were the first to provide fetal medicine services since 1987 in the country. And they provide state-of-art facilities not only in diagnosis but also in interventions. And the fetal medicine unit as well as the intervention unit of Mediscan offers the only fetal medicine fellowship program in the country and has been recognized as the first fetal medicine training center in Asia by the Fetal Medicine Foundation of UK. So with these words, I would like to invite Professor Dr. Indrani Suresh, Madam, for your talk on ultrasound in second trimester anomalies. Over to you, Madam.
Is Indrani Madam is
Indrani Madam? Yes, she is here, but Indrani Madam, please unmute yourself.
Or is Pratima Madam online?
I am online, yes.
Yeah, so if
Then
we are
shall
not
we
able to
start
get,
with Dr. Pratima?
yeah, Ambuja Madam will start, and then meanwhile,
I think then Dr. Jyoti, can you please introduce Dr. Pratima? By the time Indrani Suresh Madam will get ready, maybe, yes. Over to you, Jyoti.
Please unmute yourself, Jyoti Madam. Please unmute your mic. Yeah.
It's my pleasure to introduce an excellent speaker, a beauty with brains, Dr. Pratima Radhakrishnan. She is attached to Bangalore Fetal Medicine Center, IMA Fetal Care Center, and Manipal Hospital, Bangalore. She has a diploma in fetal medicine, FMF certified, first Indian, diploma in advanced obstetric ultrasound, RCOG UK. She was the first to perform therapeutic fetoscopic laser and first to start online distance learning. Fetal ultrasound benefiting several doctors across the country. Her special interests are definitely fetal diagnosis and therapy. And she's had lots of orations, best paper presentation, and successfully advanced fetal invasive procedure being performed by her. She pioneered the first trimester screening and diagnosis in India, several national and international presentations to her credit. Her role models are none other than Professor Nicolaides and Professor Lindsay Allen. On to you, Dr. Pratima.
Thank you very much, Dr. Jyoti. That was a very kind introduction. With that, I will just move straight away to my presentation because I've got a few things lined up for you. So the topic was you find something on the first trimester in terms of anomalies. I have actually included markers also because markers are more common than anomalies. And what do we do as obstetricians? You know, sometimes things can be a bit confusing, and you know, you would be wondering, and of course, not all patients behave exactly the same. Similarly, not fetuses behave the same either. So as just a broad spectrum, so I've tried to cram in as much as I possibly could, but I'm happy to stop whenever you tell me to stop. So that's fine. So we know that the first trimester scan has become an extremely important scan, and it is not only it's not anymore just an NT scan, because we know that we can screen not only for chromosomal abnormalities, we can look for fetal structural defects, we can screen for maternal preeclampsia, fetal growth restriction, etc., and this carries on. And you know, we have evolved so much in the last 15 years, ever since I started doing my first trimester scan about 18 years ago when I trained with Kypros Nicolaides, when we were just we had completed the NT studies and we were just started looking into the nasal bone and tricuspid flow. So I'm just going to take this in the form of some case discussions and see, you know, how variable things can be. Now, we know that nuchal translucency is a function of the crown rump length, and it's very important that we take images that both of them are standardized images. And as the NT increases, as the CRL increases, which is on the x-axis here, the NT also increases the range. So therefore, it is very important for us to plot them on graphs like this, where you know for this particular CRL, this NT, is it normal or not? So it's very important to use graphs, and these are freely available on the internet, and I'm sure all obstetricians have got internet in their clinics, if not on their phones, certainly. Now, this is a baby who was fetus which was referred to us at around 12-13 weeks with an increased nuchal translucency. Yes, there was increased nuchal translucency, but then you can see that the profile doesn't look quite so right, and we did suspect micrognathia. As usual, we advised them to do a CVS, and then the karyotype came back as normal. And a few later after this, because there was suspicion of micrognathia and the NT was a bit increased, there were two things there. So we told them to come back for an early anomaly scan. When she came back for an early anomaly scan, the micrognathia was more prominent. It was confirmed. In addition, there was a cardiac defect and the short long bones as well. So there was a major cardiac defect. There was a left axis deviation. There was a VSD, a perimembranous VSD, overriding of aorta, pulmonary stenosis, and tetralogy of Fallot. So now you have increased nuchal translucency with normal karyotype. In addition, there was micrognathia and there was a cardiac defect as well. So this needs to obviously be investigated further because it's not a chromosomal abnormality. So now you're thinking of the rarer forms, which is a genetic abnormality. Now, this particular baby determinated the pregnancy, and this was the postnatal. So chromosomes we know was normal, but unfortunately there was no DNA stored for this baby ductus venosus waveform. So the risk for chromosomal abnormalities went up from 1 in 1300, which was an age-related risk, to 1 in 11, so significantly high. So we did a CVS, again the karyotype was normal. So when we brought her back at 18 weeks, there was a major cardiac defect, which was consistent with tetralogy of Fallot with pulmonary stenosis, and they underwent a termination because they preferred to do a termination rather than. We know that some of the tetralogy of Fallot are operable and the kids tend to do well as well, but because it was less than 20 weeks and the parents were anxious about postnatal morbidity, they preferred to undergo termination. So cardiac defects also can present with increased nuchal translucency in the first trimester, right? And of course, the recurrence risk will vary. Now, sorry, this should be case 3. This should be case 3. So there was this is 27-year-old prima gravida, spontaneous conception. This was a twin pregnancy. Please ignore that. This was a twin pregnancy, and she was referred with increased nuchal translucency. As you can see, the nuchal translucency is 6. There was bilateral jugular sacs and was reported bilateral hydronephrosis and echogenic kidneys. But when we scanned her in our department, the kidneys looked reasonably okay, and neither were there echogenic. So there was increased nuchal translucency, and there was a little bit of jugular sacs as well. That's not a great image. So we did a double CVS, and the karyotype of both the babies turned out to be normal. Subsequently, we saw them back at the anomaly scan, and by that time, everything had settled. From 6 mm, it had gone down to normal, and the outcome of this pregnancy was they were a normal set of twins at 35 weeks. So increased NT in the twin one remained unexplained, and this can happen as well. So once you're excluded chromosomal abnormalities, structural defects, cardiac defects, and it can occasionally remain unexplained also. Now, the same thing we carry on to generalized fetal edema and cystic hygroma. We must remember the management is pretty much the same. This is nothing suddenly different to increased NT because it is a continuum of increased NT, and it is pretty much managed the same as increased NT. Now, it's very important that when we look at these babies, we need to look for other markers, look for any other anomalies. If we prefer to do an invasive test, KT is not enough. We need to look into chromosomal microarray, and I would like to add on 750K because this is a high resolution chromosomal microarray. It's very important, and it is prenatal. And of course, early follow-up. You don't wait for 18-20 weeks, and you can do a follow-up at 16-17 weeks itself, so that what is very important is you have a completion of follow-up, because we know that questions that is usually asked by these couple, will it happen again? What was the cause? Why did it happen to me? These answers can be given only if we have a complete follow-up. And the luxury that you have in the first trimester, unlike in the second trimester, is that of time. You have time to resolve these questions. It just needs extra time with the couple to discuss that, look, this is important for your future pregnancies. Now, what happens if you have an increased NT? If you have an increased NT, as the NT increases, the possibility of finding an abnormal karyotype, fetal death, major defects, which also includes heart defect, increases significantly, and the chances of having a healthy live baby reduces. But look here, even when the NT is more than 5.5, there is a 30% chance that you could still have a normal live birth, like how we had in our twin case as well. So if you have an increased NT in the first trimester, you would suggest doing a chorionic villus sampling, or you can add on an IPT as well. You would do an anomaly scan, and of course, if there is a major defect or a major anomaly, the pregnancy is terminated at that point. If there is a normal karyotype, no abnormality, you look at the NT. If it is more than 3.5, let's bring her back for an early anomaly scan and maybe even do an echocardiography, because the heart, you can start seeing the heart well, particularly with the high resolution ultrasound, transvaginal scanning, and with more skills that has been developed over a period of time. It's possible to look for at least major heart defects. And of course, cardiac screening has significantly improved over the last decade as well. So if it is, this should be less than 3.5. If it is less than 3.5, you can go on to do the anomaly scan and echo at 18 to 20 weeks, so a little bit later, right? So this is what we would do, and come to if there is an abnormality at the 14 to 16 week, or if there is fetal death, of course, that is the termination of pregnancy. If this is normal, no abnormality, and the NT is resolving, then you would go on to do the 18 to 22 week scan. If NT, there is no abnormality, but you still have a high NT and there is edema, then you may want to consider infection screen, and hopefully you have stored DNA. Unlike our first case, we learned the lesson, so we started storing DNA in all cases of increased NT, because you don't know what you would find later. Then you can use the DNA to do any genetic testing if and as and when required. Of course, if you find any major abnormality, then again DNA testing, but this obviously has to be done in consultation with a geneticist, right? So that goes into termination. If it is all looking normal, then if it all turns out that it's normal, then you would go on with an anomaly scan and echo again. There you go. And of course, if there is no abnormality, then nuchal edema could have been resolved, and you will be able to reassure this couple very well. However, in the small instant that there is no abnormality, but there is persistent nuchal edema, you will need to follow up. Sorry, let me just move that. If they could be later, you need to warn the patient that there could be late anomalies that will present antenatally or even postnatally, and very important to do a postnatal follow-up looking specifically for genetic anomalies and neurodevelopmental issues. And generally, if you fall into this category where there is no abnormality, nuchal edema has resolved, then you can be reasonably reassuring to the couple that the outcome for these pregnancies are excellent, and that the incidence of neurodevelopmental issues in this group of babies, because you have checked the chromosomes, that is normal, you have done the heart, that looks normal, the structure of the baby looks normal, the chances of neurological or other abnormalities is extremely low. In fact, I would think it would be even better than the normally evaluated, better than those fetuses which had a normal NT, because here you have done an extensive scan and in a good standardized manner, of course, and you have also in addition checked the chromosomes, which is normal, so you can be very reassuring. However, if there is persistent nuchal edema, which can happen in about 5% of pregnancies, then there has to be a kind of guarded approach, because they can have problems in the future. And in the future. Now, the other thing, we looked into about 500 plus babies with increased nuchal translucency, and there were 3 babies with neurological developmental problems which presented at 1 year and 6 years, between 1 and 6 years. And to be honest, there was no correlation between the extent of increased nuchal and the neurological problems. So you cannot say that if the nuchal is 6, they will be bad. If the nuchal is 2.8 or 3, it will be good. No. We had baby with the 2.8 nuchal, which turned out that had quite significant neurological problems, whereas a baby with 5.6 had completely resolved and had no problems at all. So we cannot be absolutely certain about that, and that has not been resolved as yet. Okay. So let's move on to the next. Okay, let's discuss another issue that we do face pretty frequently. Absent or hypoplastic nasal bone. Very, very important to have the correct plane and to make sure that the nasal bone is indeed absent or hypoplastic, and both of them have the same significance in the first trimester. And it's the mid-sagittal view done properly in the same plane as the NT scan, and that's an hypoplastic or an absent nasal bone. And we do not tend to measure the nasal bone in the first trimester. So let's look at some examples. 30-year-old singleton pregnancy, no significant history, 60 mm, nuchal was okay, just the nasal bone was absent, and there were no major abnormalities in this baby. Now, when we did not include the nasal bone, this was just the nuchal this was nuchal translucency, the background risk 590 to 388, and when this is an age-related of, this is 30 years. Now, this should have been without the nasal bone. This is with the nasal bone. So what I'm saying is, if the nuchal translucency is normal and you put the present nasal bone, the risk is about 1 in nearly 4,000. However, if the nasal bone is absent, the risk goes up significantly. So it's important to, if you're doing the screening with the nasal bone, it's very important that you include the absence of nasal bone, because in the second trimester, you can have a present or an absent nasal bone. Now, what are your options here? Because otherwise, structurally, the baby looks normal. You could give them the option of invasive testing if the couple want to be absolutely certain. Yes, there is an option of non-invasive prenatal screening, but remember, there are some babies' chromosomal abnormalities include sex chromosomal abnormalities, and NIPT is not a good screening test for sex chromosomal abnormalities. And some babies with sex chromosomal abnormalities, some parents would not want to continue the pregnancy with sex chromosomal aneuploidies, especially when they know about it. Of course, you can give them the option of serum screening, but remember, NIPT and serum screening, that is a first trimester double or first trimester quad, will be another screening test. It will give them another number. So I think this requires a clarity on the obstetrician side to sit there and explain to the parents that the absent nasal bone does not mean the baby does not have a nose. Of course, it has a nose. It's just that the nasal bone is delayed in its formation, or you can call it delayed ossification of the nasal bone, but still the internationally used terminology is still an absent nasal. Okay. Now, on the other hand, you have a baby with an increased nuchal translucency and there is absent nasal bone. So you've got two markers. And of course, in this case, the same baby, the risk goes up significantly. And in this case, there is not very much doubt that you need to do an invasive test to assess the fetal karyotype. Okay. Now, of course, you can have multiple markers, but sometimes you can just have an isolated marker. It could be an absent nasal bone. It could be tricuspid regurgitation. It could be a ductus venosus, abnormal ductus venosus with a normal or an increased NT. Now, of course, with an increased NT, as I showed you, the risk goes up significantly, whereas with a normal NT, the risk goes up a little bit. And then what do you do with these isolated markers? We looked into our data with 460 fetuses with markers, of which 93% of them, that means majority of them, were isolated. That means you had only a single marker, either an increased NT or an absent nasal bone or abnormal tricuspid Doppler or an abnormal ductus venosus Doppler. So in this, about 11 babies had karyotypic anomalies, which gives a possibility of 1 in 39, which is about 3% possibility of finding an abnormal karyotype in this group, the entire group. So when we split it, there were 230 babies with isolated increased nuchal translucency above the 95th centile, and 9 of them had karyotypic anomalies, which is 4.3%. And when it was isolated nasal bone, 2% had abnormal karyotype. The numbers for the ductus and the tricuspid were not significantly high. I mean, small numbers, therefore we have not yet found, but obviously these studies have to continue. The more numbers we have in these groups, the more likely we are going to find abnormalities, which also means that many times tricuspid regurgitation can be associated with other things. Now, I'm talking about structurally normal babies here. So you have made sure the baby does not have any structural abnormality and just a marker is present. So we've already done a detailed scan and we have made sure that no other markers and no other structural abnormalities. So in effect, you can say about 4% of babies with isolated increased NT, that is 1 in 25, would have a chromosomal abnormality, and 1 in 50 with isolated absent nasal bone could have a chromosomal abnormality in general. Of course, this would vary from baby to baby. So, but this would help us in counseling the couple that in the presence of multiple markers, the risk goes up significantly. If there is an isolated marker, also there is a risk compared to normalcy, of course, and the risk is about 4% and 2% respectively. Now, what about fetal defects? Now, fetal defects can be detected reasonably well in the first trimester, and this is the target 9, which really should not be missed in the first trimester, of which we know that acrania, encephalocele, alobar, iniencephaly, body stock anomaly, these are lethal abnormalities. Limb reduction, yes, majority of the parents, if they know that there's limb reduction defects, they would not want to continue with the pregnancy. And let's look into these ones which are less, they're not exactly lethal, but they can change over a period of time as well. So now this is a baby with the normal nuchal translucency, but was referred to as with persistently distended urinary bladder. And of course, that is megacystis, and that megacystis was about 11 millimeters. And when we did a further scan, we found that the baby had indeed increased nuchal translucency. In addition, it had holoprosencephaly, it had a cleft lip and palate, and complete a midline cleft lip and palate. This pregnancy was terminated at 13 weeks. Now, if this pregnancy was terminated at 13 weeks, as usual, what will happen? They come back in the next pregnancy, no investigations done, and they want to know what is the cause and will it happen again. Now, the question is, how are you going to counsel this couple? Looks like very likely this was trisomy 13 because you had all the markers of trisomy 13. You had increased nuchal translucency, holoprosencephaly, cleft lip and palate. Everything looks like trisomy 13, but can we be absolutely 100% sure without knowing that without having confirmed the fetal karyotype? So think, it is the abnormal babies that need to be investigated. No, when you have a problem, that's when you go to the doctors and you do all your tests. When you're otherwise completely normal, you don't go to the doctors, you don't do your routine tests. You just do only your routine test. You don't do any extra tests. Similarly with babies, when babies have problem, they need to be investigated. That's when you will be able to give answers clearly to the couple. What is the cause? Will it happen again? And will it happen again is an extremely important question in our setup, particularly because we do have a lot of marriages which are consanguineous, more importantly, within the community. Now, even if they may not be consanguineous, but marrying within the community also keeps the genetic pool, the bad genetic pool in the community for many decades. It's been happening, right? So even though they're non-consanguineous, they can still have genetic abnormalities. So if you really want to be, complete your job of assessing why this happened, will it happen again, you need to investigate these pregnancies. Okay, let's look at another case. This baby was referred to us at around 15 weeks. The increased NT was reported in the first trimester, and it was an optimally done NT. And she was referred to us just for a blood test, and we sat down with her and said that, look, yes, NT is increased 3.3, but and she was referred for an NIPT. So before an NIPT, we always counsel the couple, like to talk to them, and many of them do agree to talk. And we say that, look, I know this has been done at 12, 13 weeks, the images are good, but we always like to have a look at the baby before we do the NIPT, because NIPT should be done in structurally normal babies. And this is why when we did an early anomaly scan, things can change. There was jugular sacs, there was bilateral echogenic kidneys, there was early onset fetal growth restriction below the 5th centile, and in addition, there was a major cardiac defect. There was a hypoplastic left heart with endocardial. You can see this bright white septum, and there was no flow across the mitral valve. So there was a suspicion of endocardial fibroelastosis. Unfortunately, we did offer invasive testing to the couple rather than an NIPT, but unfortunately they terminated the pregnancy. So they didn't do the NIPT, they didn't do invasive testing, so we have no idea whether this was a heart defect or whether this was primarily endocardial fibroelastosis or something else, because in the next pregnancy, you will not know why this happened again. So there was increased NT also in the first trimester. So it was left with no answers for the future, right? Now, what about certain defects which will resolve spontaneously, and so we need to wait? We're not in a rush to terminate. The luxury of your first trimester scan is that you have enough time to resolve the issue, fortunately. Okay. Now, bladder when it is less than 16 millimeters, when it is more than 7 millimeters, it is known as megacystis. Between 7 and 15 millimeters, about 85% of them will resolve. There are a few reported miscarriages and bilateral hydronephrosis, but these are the ones, about 10% of these will be associated with chromosomal and genetic abnormalities. So it is recommended that you would do an invasive test to check the chromosomes, and you would rescan them at 16 to 17 weeks, because many of them, more than 80% of them, could resolve. This is just because of a delay in the sympathetic and parasympathetic system maturation, which innervate the bladder, and therefore the babies are not emptying their bladders very quickly. But this can happen in normal babies, and it can happen in abnormal babies also. Therefore, it's very important to check the karyotype, right? Now, something like that cannot be missed on scan. It's a huge bladder, which is more than 15 millimeters. Even in this group, you can have aneuploidies, but this is not something that is going to resolve. So you would offer them karyotyping. Whether there's a role for fetal intervention, this is still, debate is going on. So if parents are keen on continuing the pregnancy and give it a chance, again, I would say, because she's only 15 weeks, you're give it a little bit of time, get them around the fact that you don't have really the baby's kidneys are packed up, because we would do a psychocentesis, etc. There is some experimental therapy is going on with fetal cystoscopy, but of course the results are waiting to be seen. But majority of them, of course, do not do well. But sometimes the parents need time to think about it, and nothing dramatically is going to change between termination at 16 weeks and termination at 19 weeks, right? We all know as obstetricians, the procedure is the same, and nothing more you need to do. There's no much higher risk at 19 weeks compared to 16 weeks. But mentally, the parents need to accept that this is the way forward, because this is very important in the long term as well. Now, the other anomaly is exomphalus, and of course, some of them can, end up with miscarriages, or some of them can persist. But again, more than 95% of them will resolve. However, if the exomphalus contains the liver, the chances of resolving is very less, or also nil almost. What they persisted and postnatal correction, required postnatal correction, were the ones which contained liver and of course the gastroschisis. If you have a small exomphalus, like something like that, those are the ones which are most likely associated with aneuploidies, and therefore they are the ones that need to be karyotyped, and they are the ones that are going to resolve as well. However, if your exomphalus has got liver, or if it's gastroschisis, that means the bowels are just floating freely inside the amniotic cavity, then they are unlikely to resolve. So it's very important to have this clear distinction between them and understand how things would change in certain structures as the pregnancy advances. Okay, so a quick word about twins. We can do serum, we can do ultrasound in the first and in the second trimester. We can look at the nuchal translucency, nasal bone, tricuspid Doppler, and the ductus venosus Doppler, but never serum on its own. Never the double, triple, quadruple. Any serum screening should not be done on its own, and it should always be combined with the ultrasound. And of course, if there's more than twins, then it is very important that we stick to ultrasound. And if they're going to undergo reduction, even in twins, we stick only to ultrasound and do not do serum screening, because serum screening is pregnancy specific, whereas ultrasound is fetus specific, right? So if you have discordant markers, discordant defects, then of course these require far more challenging. Then you may have to consider double or single invasive, whether it is dichorionic or monochorionic, it doesn't matter. It's sometimes even in monochorionic, you have to sample the edge, particularly if they're discordant. You can have discordant karyotypic anomalies in monochorionic twins as well, right? And of course, in sometimes, particularly in the presence of defects, the couple may opt for reduction of the affected twin, but it is again important to CVS or karyotype the normal twin so that we know what is continuing for the pregnancy, in the pregnancy, is normal as well. Now, why is it important to do first trimester screening and first trimester scan in multiple pregnancies? Because reduction, the pregnancy loss with reduction is much less. And of course, it's early is better. And of course, chorionicity is extremely important, because the way you would reduce will depend upon the chorionicity. And course, a step further in monochorionic twins, you would think about possibility of twin-twin transfusion syndrome and selective growth restriction, which can have markers in the first trimester. So let us look at some genetic syndromes. Now, this is a couple who was referred to us with a previous baby, which was reported to have Down syndrome. So she comes, the first pregnancy was a miscarriage, second one was terminated, and they just told us verbally that that baby had Down syndrome. And this is the third pregnancy that they had come to us, and you can see the nuchal translucency is just a little bit increased. The nasal bone is hypoplastic, and there is a major cardiac defect. There was an AVSD, which is unbalanced. The left, there was not much flow across the left ventricle as well. So we had all the markers for trisomy 21 again, or for Down syndrome again. So, you know, they were a bit shocked that he said, last time we had Down syndrome, how can we again have Down syndrome? I said, okay, let us have a look at your previous report. And when they come back with the report, this was the report: balanced translocation karyotype 21, recommended parental karyotyping. Unfortunately, this report was not seen neither in the fetal unit nor by the obstetrician, and and the parents also did, either they did not show it or they did not take it with them. It was not reviewed. You can have n number of reasons, and they had clearly said recommended parental karyotyping, but it was ignored. So when we did we did a CVS for this pregnancy, and the karyotype confirmed that it was recurrence again, which showed a balanced translocation in the again, and there was genetic counseling, and the mother also had balance. Sorry, should be unbalanced translocation. This is mother had a balanced translocation, right? So mother was a carrier. So the recurrence risk for this pregnancy will be many times. Every pregnancy will be many times higher. Okay, so this is a flow chart. So if you have just a plain trisomy 21, the recurrence risk is about 1%. So there is no need to do parental karyotyping. In the same thing with the mosaic, the recurrence risk is even lower. So there is no requirement to do parental karyotyping. However, if there is a translocation involving trisomy 21, the recurrence is much higher, and therefore it is extremely important to karyotype both the parents to understand what type of translocation it is, whether it is 1421 or 2121, because if it is 2121, the recurrence is almost 100%. Whereas it is 1421, it's again depends upon who is carrying, the mother or the father. It can vary from 12% to 3%. So very important to know what type of Down syndrome that was. And Down syndrome is not enough. You need to know whether it was a trisomy 21 or whether it was a translocation involving chromosome 21. I just like to bring to your notice the fetal logs, which in the first fetal log, it still is very relevant. We've got a lot of things on genetics, and it's on our website. Now, this is another couple which was referred to, which is an old case of mine, was referred to us with a bad obstetric history. The first baby was all right. The third, she had a couple of miscarriages. The third pregnancy was not seen by us, but was reported, it was a neonatal death because they could not intubate the baby. And when they did the pathological examination, the baby had no trachea, there was bilateral microphthalmia. And this fourth pregnancy is when I saw her for the first time. There was a major heart defect, and we picked up my bilateral microphthalmia as well. In between, and then there were two pregnancies that had similar thing, and the pathologist made the diagnosis of Matthew Wood syndrome, 2 miscarriages in between, and then she came back in the 7th pregnancy, and you can see the profile is not so great. And when you look at the heart was almost in the axilla. There was nothing there at all. So there was bilateral the pulmonary agenesis in this. There was unilateral pulmonary agenesis in the 4th pregnancy. And here again, we were suspecting the heart per se looked normal, but there was no lung there. And when we looked into the eye, there were no eye sockets either. So this was a recurrence of Matthew Wood syndrome. This pregnancy was terminated at 14 weeks, which is much kinder to the pregnancy, of course. This does not require any invasive testing because there was no DNA level diagnosis that was available. So we have to go with ultrasound. Fortunately, she's not come back. I think they were satisfied with having one child. Yeah.
Very nice talk, but yeah, because we have Indrani madam also waiting.
Yeah, sure.
But I couldn't, actually, it's very difficult to stop you also. Such an interesting talk, I should say.
No, I'll just come to my last 2 slides, right?
Okay, thank you, thank you.
Yeah. No problem at all. No problem. So I think it's very important for us as obstetricians to understand it is our responsibility to accept a first trimester scan report or reject a first trimester scan report. Something like that is absolutely not acceptable. You cannot even see the baby, forget about the NT or the nasal bone. It's badly measured. It's very important as obstetricians, you should be trained what to see as a good NT scan. A good first trimester scan will include all this information and much more, but not a low-lying placenta, or low-lying placenta, how does it matter to you? Or subchorionic hemorrhage, if she's not bleeding, what are you going to do about it? Right? So you need to really think, what is the importance of the first trimester scan? Yes, it is an intrauterine scan. You need to know number of fetuses, and if there are more than one fetus, you need to know the chorionicity, good crown implant, gestational age, nuchal translucency, and other markers if they're good at picking other markers. But the least you should expect is a good nuchal translucency in image like that. A system-wise assessment of the baby, whether anatomically the baby looks all right, uterine artery Doppler, and if possible, risk assessment for aneuploidies, preeclampsia either. If not, at least you can yourself go to the Fetal Medicine Foundation website and calculate that. So with that, I just need to keep, it's very important for all of us to be updated regularly, and there is no better way than keeping ourselves updated than internet. And of course, I do recommend Fetal Medicine Foundation. There's another thing called Up to Date, which also keeps you up to date with many things that happens across the world as well. So very important to keep ourselves up to date. Thank you very much.
Thank you so much, Dr. Pratima. I'm really sorry for interrupting
you.
No,
Please, not at all. No, that's fine. I mean,
okay. So please wait for the discussion.
I will certainly.
We will see whether Indrani Madam has joined.
Certainly.
Madam, have you joined? Indrani Madam, are you there?
Yes.
Madam, I have already introduced you, and you can go ahead with your presentation, Madam. She is going to talk on ultrasound in the second trimester, detection of anomalies and way forward. Over to you, Madam.
You can hear me?
Yes, very much.
Okay.
Please share your screen, Madam.
Sure. Can you see my screen?
Not yet.
Not
yet, Madam.
I need to drag the presentation and put it over there.
No, Madam. Kindly open your PPT.
Yes, I am opened it.
So then again, you come back to Zoom meeting window.
Okay.
You can see bottom share screen.
Share screen.
Yeah. You click there, and another meeting window will pop up. Select your PPT and share, Madam. You can search by yeah, perfect. You can slideshow. You can put it slideshow. Again, stop, Madam. Kindly share it again.
Can you?
We can see your screen.
Okay. Is my slides visible?
Yes,
Madam. Very much.
Perfect.
Fine.
Please go ahead. Please go ahead.
Good afternoon, everybody. Thank you very much for calling us to speak in this particular topic of fetal anomaly, because I had seen this session you had discussed on the maternal aspect, which we need to look into. Similarly, we need to look into the fetus as well. And we had a good introduction by Dr. Pratima in the first trimester. What are the things that are to be done and how we need to update ourselves, and as clinicians, how we need to look into the reports intently. Right. So when we move on to the second trimester, just before starting the second trimester, we have reached the era where we have good equipment, and we have also got the ability and skill sets. All those anomalies which has to be diagnosed, lethal ones with high morbidity in the first trimester, so that it reduces the emotional trauma to the family and also to the clinician on handling the patient. So with that, we move on to the second trimester. Again, in second trimester, the performance of the test has to be done appropriately. We have been following this rule of 3 over 25 years, and it is found to be very useful. Of course, now we have other guidelines also, ISHWA guidelines, FMF guidelines. We need to follow guidelines and then have a checklist-based approach. So we have done that.
we have a group of babies where it is predominantly 95% of them going to be normal, and a small percentage with borderline findings, and then a small percentage with problems. So we need to proceed. How are we going to proceed further? So we need to see, we are having some ultrasound findings and we have to make it a correct diagnosis. So to diagnose, we have to make sure it is completed, and then we look into further the testing, what are to be needed. And then we look at the outcomes, whether it is lethal or variably lethal, or non-lethal abnormality, but can have a high morbidity like open NGD. So then once we have an abnormality, we should not have a knee-jerk reaction. We should take step by step. So we need to look at the baby as a whole and plan on doing further tests on the fetus as well as certain times on the parents also. And finally, we group which is the way we are going to look into continue the pregnancy and follow up, discontinue the pregnancy and do later on any testing. So the dilemmas we have, can we always come to a conclusion when we have a finding? Are we complete in our diagnosis? And is our diagnosis right? Because we do see after postnatal examination or in autopsy or clinical examination of the baby, we can have some additional problems as well. The implications, we know about what is seen. More important is also what you are not seen also. We should have some idea. We should be able to discuss on that. So the most important thing is when and who should reveal the information to the patient. Immediately after the scan, the patient would turn down to the person doing the scan and ask, is my baby all right? Immediately they want all the answers. It's most important that we need to have all our data in the hand and then talk to the patient. The goals of counseling should be the decision making, short-term and long-term outcome, immediate outcome, how we are going to look at it. So we'll look at the counseling. You make the parents understand the findings, put the findings together, do a pedigree analysis. The pedigree analysis helps because somebody is just talking to them and analyzing their family and all that, they come a little closer and chart a plan of action and recommend further testing and then help in the obstetric management decision. So when we have a baby, as Pratima rightly said, the fetus is the affected individuals. Many times whenever we have a baby with a problem, immediately they say it's not going to be all right. Then we would rather terminate than on spending on the test. As the same way as she said, I explained, if I'm not well, I'm going to undergo test. Same way, fetus is not well, we have to do the testing on the fetus. So what are the tests needed, when we have to do, and the test could be as well as starting from your routine karyotyping to box molecular testing and then chromosomal microarray, exome sequencing. And once we have a result, we need to discuss the results because we how they are going to take it up further, because there are a couple who have come with a trisomy 21 positive result, but still they are expecting to follow the pregnancy because they have an idea, they want to understand trisomy 21 Down syndrome and then continue the pregnancy. So we don't make choices for the patient. We explain everything to the couple. We will go by a couple of 5 cases. So it is this is the second gravida with the first baby doing well. Uneventful antenatal period at 18 weeks. It is rather an early target. We can see both the feet are showing a talipes deformity. So a minute. Can I just minimize? Better. What is meant by isolated abnormality? We need to see extensively the whole baby. Additional testing required, and then we need to convey to the parents. So here is an example where we have a baby with, as opposed to what we saw earlier, we have a baby with unilateral talipes, right side, other side was normal. So it is different when you have a unilateral talipes and a bilateral talipes. It's not moving. Okay. So when we have a talipes, it could be starting from idiopathic, or it could be because of the oligamias overcrowding, like in twin gestation, to complex talipes, where it could be a part of a musculoskeletal problem like arthrogryposis with syndromes, with secondary to neurological spina bifida and chromosomal problem. So most important, as we have been talking, we have to update ourselves. Even we have been doing for practicing for 30 years. It's important to get literature search on that. And most important is the systematic reviews give us a better idea. So we need to review the evidence and then read the contents rather than just jumping onto the conclusion, and then keep updating, which will help also get the help of the subspecialists when needed. So is this talipes truly idiopathic? That means it is just a peripheral one, but without any other problem. But we have seen that you can have associated anomalies in 7 to 8%. So we need to screen intently the baby. Is this diagnosis, can you have false positive because this is a wishful thinking of the parents? Can it be, the diagnosis can be wrong, it can be all right? Yes, especially when there is a high BMI, positional, and then multiple gestation. You could have sometimes, these are the times when we say the foot is rather little inverted, possibility if you are not able to say firmly. Can an isolated talipes become complex later? Yes. Evolving arthrogryposis. To start with, it would be in the peripheral parts, and then progressively it can increase in the late third trimester scan. So what are the outcomes in unilateral and bilateral? Unilateral, as isolated ones, have a better outcome compared to the bilateral ones. So the next question is, do we need to do a karyotype for the pregnancy? Isolated talipes, the association of chromosomes is low. And if you have a bilateral talipes, one of the common chromosomal association is trisomy 18. So chromosomal microarray has not been found to be giving any additional improvement in the genetic testing. So what are the key messages? You have an isolated talipes. If it is bilateral, we screen properly and then do a karyotyping, consult them. And then we take the baby through. We have, these are the ones which can be managed without surgical management, quite a bit of them. And what we need to see from birth, serial casting need to be done, and then tendocleistomy and bracing, so that obviously by the time the baby starts putting the feet, we have to explain them. By 8 months, we are getting the baby ready with the feet. But this braces has to be kept for a couple of years. So it is a treatable anomaly with a good outcome. We move on from that to a case where we see this is a primary gravida, married for 6 months. There was no first trimester scan. Target scan, as you see the spine here, it is looking quite abnormal, and also there is a bulge over there, and that is an open neural tube defect with a lumbosacral meningocele with a few segments, vertebral anomaly as well. So when we say an open NTD, the morbidity, what is the extent of the morbidity? So this is what we see here, and the motor involvement and rehabilitation, intelligence 50% can be affected, and then continence, which is something which we have to really bear in mind. Even closed NTDs, they can have incontinence. When you have an open NTD, it is very high. And what all the baby will require to close the defect? Shunt the hydrocephalus, and then at the end of it, they may require self-catheterization and orthopedic management for mobility. So the most common response for the people is immediately any problem the patients ask, is there an option to correct the baby by medical management? And then comes, of course, surgical management. So it is important, it is for us to update on the prenatal surgery. So talking about the high morbidity, understanding the preferences, because there are a couple who want to conserve the pregnancy and give their best, so we have to respect their feelings. Coming to intrauterine surgery for meningomyelocele cases, the MOM style, this is an open surgery, as well as it can be also done by a laparoscopic method, where in utero you are closing the defect. So this leads to less hindbrain herniation, better neurological and motor developmental scales. But you have the problems of the maternal complications like rest of the pregnancy it can give way, the scar can give way. And then subsequent obstetric outcomes, because you are going to open up the uterus around 24 weeks and then doing all these things. So it has got a higher chances for future morbidity in the future pregnancies. So the next question comes, this is mid-pregnancy scan. Could we have diagnosed this early? In the early 1980s, it was more by serum alpha-fetoprotein and amniocentesis. In 90s came the lemon and more strong 100% sensitivity, the banana sign. And currently we have a good intracranial signs like obliteration of intracranial lucency. So putting in this obliteration of intracranial lucency, which is similar to your banana, and also the brainstem occipital bone measurement, and a smaller sized head and less fluid, what we call as a dry brain, all this can make almost close to 95% diagnosis of these large open neural tube defects. But of course, we need to improve our expertise. As in the last slide, Pratima showed this various kind of bizarre labeled pictures. We should performance of the test, and we have to keep updating ourselves as, and also it is a responsibility of the clinician also to ask and look at the pictures. So if the patient asks, how do we convey this? Then we need to see. It requires more expertise, and we could definitely offer that in the subsequent pregnancy. If it is going to be an isolated open NTD, most likely it is multifactorial, and then folic acid and B12 in the periconceptional period could have about 70% protective effect in preventing the recurrence. But also very important, even after the fetus is, if it is terminated, we make sure that external examination, X-ray examination, because it's not a part of some syndrome, which is very, very important, because there your folic acid coverage is not going to be of help and the counseling will be different. We move on from to case 3. Here you can see a fetus at 21 weeks. You can see a good amount of liquor around. You have a good bladder, which is filling and emptying. And you have one kidney nicely measured, and it's also showing a little renal pelvis fluid there. But then the other kidney is not visible in B mode. And then also while doing a color Doppler, we found there was no renal artery. Search for the kidney elsewhere in the pelvis, we couldn't figure out. And on transverse scan, you can see one kidney nicely made out. And also currently with 21-week scan, if you have a higher resolution probe, we should never hesitate to look at it for looking in the other locations like in the pelvic kidney. So at the end of it, you have a baby which has got a unilateral single kidney. The other kidney we are not able to figure out. And so what is, we need to look carefully for other urinary system issues and gastrointestinal issues, cardiac issues, and extended imaging. This is where whenever we find a problem in one system, we need to do an extended imaging. So part of extended imaging, we need to look at the anal muscle complex, because you can have imperforaneous genitourinary abnormalities. And also we need to get a history from the family, any in the family, and the issue of parental kidney screening, because renal anomalies, anything in the parents could have a recurrence like that in the fetus as well. But it is a very tricky issue. We have to counsel them, talk to them, and then only make a consent and then put a case sheet and then do the parental kidneys. Because some years ago, I would say some 15 years ago, whenever I talk to the patient, they will say, never mind, screen my kidneys. And I also used to look at the mother's, father's kidneys, make them sit, and through the back approach, I will look at the kidneys. But that is not appropriate. We have to do in a proper manner. So the parental queries are we sure that nothing else is abnormal? What if the other kidney becomes abnormal over a period of time? Is one kidney enough for lifelong? Will my child have a normal lifespan and be like other kids? This is the common question they ask when you say unilateral renal problem with other kidney being normal, and it could be renal agenesis, it could be also multicystic kidney with the other kidney being normal. This is where when we look at the references from the nephrology, pediatric references, we need to see postnatal references, we need to see. Kaput is congenital anomalies of kidney and urinary tract, where they say other anomalies like you can have a megaureter, duplex system, and erythrocyte, and extrarenal. So all this we need to have. Even small percentage can have late onset of problems like hypertension. The key message in this particular case is we need to do a evidence-based counseling, and we cannot say, oh, I'm sad, or it's okay, you can have a baby, there's no problem. We should do a pragmatic counseling. And for that, we need to do literature search and have an idea, basic idea. It is not that we have to tell 10%, 15%, 13%. Like, we need to give them an overview of what we need to see as the pregnancy advances and postnatally. So it is important we need to upgrade our skills. Coming to the fourth scenario, here again you can see in the 3D picture, it is a unilateral cleft lip and palate also is there. There is a disruption in the maxilla. That's and it is a cleft lip and palate which was just extending for a short this anterior palate. And yes, similar approach we need to see in the kidney. The simplified approach would be this is a common abnormality, you can correct it, and then postnatally baby will require surgery. Is this as simple as that? We need to start from the social and emotional. As soon as the baby is born, everybody is going to see. The mother also is going to be quite emotionally affected because it is overt, unlike a cardiac anomaly. Cardiac anomaly baby, even if there is a major cardiac anomaly, parents are not too upset. But whereas when they see a cleft lip and palate, they are extremely emotionally upset. And we need to look at what are the evaluation options. Then again, we look into the systematic review. Association of chromosomal abnormalities with facial cleft. When you have a unilateral cleft lip and palate, you have a zero association. If you have even isolated cleft and associated anomaly. When you have isolated cleft, the association chromosomal abnormality is very small. This just tells isolated cleft palate because they have included 13 postnatal data because cleft palate isolated, it is too difficult to diagnose antenatally. Most of the time it is a postnatal observation. When you have associated anomalies, look at the numbers, the genetic association is as high as 40 and 50%. So it is important we have to look for all the associated anomalies. And again, when you have the unilateral, the associated anomalies is a little lesser compared to bilateral, you have higher associated anomalies. So what are the associated anomalies as we saw in 13 trisomy, you can have cleft lip and polydactyly, and you can have clenched fist and 18 trisomy. And you can see a slash defect on the face, amniotic band syndrome, you can see the band affected. This we could diagnose in the second trimester because the baby was not opening the hand only. Then we found this band and then syndactyly we made out. You can have cases with cardiac anomaly and also part of arthrogryposis. Most important is when you don't have all this, when we are looking at the pedigree, you see here, in this pedigree, this is the affected fetus in utero. One sib is affected, and then mother is affected, and the grandmother as well is affected. So it is very important when you have a cleft lip, we need to consider detailed anatomical assessment and genetic assessment, and then we need to have our case files because it would be very useful for us to do a cross-referencing as well. There are so many syndromes that are being highlighted. I don't want you to get worried about that. The question asked is what would be the recurrence risk? As you see here, the recurrence risk goes if they have more than two affected SIP or a parent, recurrence risk goes. Otherwise, it is only 2 to 3%. And what could be the postnatal care plan? The lip can be operated by 3 months. Around 6 to 8 months, the palate is closed and followed by, most important first step is your speech. The dental also comes later. So this also has to be looked into so that you will have a holistic care of the baby. The postnatal care is not only talking about this surgical maneuver, Also important, accepting the problem. This is where when you have your database, that's what we do. We recommend there are a couple who are happy to share their experience with the others. And this is how we link them together. This cross-counseling helps for those who are planning to continue the pregnancy about the uncertainties. And it improves the outcomes better because they are able to first accept the baby. And also as they are raising the child, I've seen parents who have raised the child with more positivity, the babies also do very well. But whereas if the parents are always upset about and looking on always the negative, defective part of the baby, those children tend to have emotionally more affected. Coming to the last case, we are in this. This is a Gravida 2, abortion 1. This is a maternal uncle marriage. This is second degree consanguinity, which we do see in Tamil Nadu quite a bit and Andhra Pradesh because patients come from there. Maybe in Karnataka it is less, but in southern states, marrying a maternal uncle is not uncommon, even the current days. The first pregnancy was terminated. I want you to look into the detail. It's 5 months, it was both femora and then termination, no test then, no clinical photograph, no x-ray, no autopsy, nothing. And then she was referred in the second pregnancy at 16 weeks for a shorter bent femur. And you look at this biometric parameters, the head and abdomen are corresponding around 16 weeks, whereas the femur was lagging by 3 and 4 weeks. And when we looked at, we found both the femora were short and bent, other long bones were normal, upper limbs were normal, hands and feet were good, baby was moving well. So we thought previous baby also both femur affected. Now also the first possibility we thought bent femur, focal femoral deficiency, it could unusual phases bilateral, or it could be other conditions like campomelia and osteogenesis. But the problem here is we put in our report bilateral short bowed femora, possibility of focal femoral deficiency. I will come to that why we should not be dogmatic in that. Then the baby they opted for termination. Got terminated, you can see both the thigh are short, whereas the leg is reasonably long and the feet are looking all right. But then you do an X-ray. X-ray reveals a whole lot of things like poor mineralization of the skull. The upper limbs were a little shorter, but most important is poor mineralization. This is actually an old X-ray taken some 15, 18 years ago. You can see both the femora are bowed, but poor mineralization and crumpled, which is very typical. We can make an X-ray diagnosis with this as osteogenesis imperfecta. So the final impression is this osteogenesis imperfecta type 2B after X-ray and histopathology. So this is what we say, whenever in skeletal abnormality, we have to be very cautious in not giving a dogmatic diagnosis. Retrospecting, there was a previous history of skeletal disorder, bilateral short femora and bent. Even the previous report said like the previous pregnancy. But fractures in the hypomineralization and then crumpled one, hypomineralization, this is something which is hard to figure out around 16 to 18 weeks in pregnancy because as such the skull is thinner only in 16 weeks. So it is important not to label skeletal dysplasia prenatally, report the findings, except in few cases like achondrogenesis, you could give a diagnosis in the first trimester, but always store the DNA. I would say for any anomaly, it is important to store the DNA because especially in the COVID times, people come at different times and prenatal testing, it is very expensive. So people have no money, they say it is difficult. Currently, I am encouraging and a lot of cases are coming after delivery. What we can do is we can store samples from the fetal skin. And this is a very good source. Skin, from there we can extract the DNA and then do a whole lot of tests. So that would just storing the skin biopsy would cost about around 4,000. Subsequently, we can spend after having a phenotypic information and other things, we can narrow down on sending higher end molecular tests as well. So putting everything together, ultrasound is an excellent clinical imaging tool. I tell patients, like how you bring the baby in hand, I examine the baby, like that you have brought the baby in your tummy. I am examining all the parts in a systematic manner. So once the diagnosis of anomaly, it is only the beginning. It is important to have a multidisciplinary approach, as we saw in various cases, and improving the accuracy by constant audit. As we said, always we look back into the cases and audit where we went wrong, how we can. So skeletal abnormality, whenever there is uncertainty, we never give one label. And postnatal examination, clinical examination, live-born baby or perinatal pathology, and genetic testing. It is very, very important. Genetic is there in a big way. We can offer so many molecular testing. Costs have come down. So we could try to fix up, because many of these skeletal abnormalities we cannot make out in the first trimester. So it is not, we can't just say in my previous case it was like that. So this also must be all right in an anecdotal case manner. We need to do our literature, keep updating our knowledge base. That's very important. We need to be supportive for the fetus as well as for the family, because they all have so much guilt in them. So it is important. It is just not one session. Many a times we do a couple of times counseling. Immediately we give the information. They are not able to take in everything. And then they come back after in the evening or next day to get more information. The more experienced we are, I really, before talking, I just make sure I am updated and I practice what I'm going and how I'm going to convey. Because it looks to be, we know little lesser than what we had really known. And team effort is very, very essential. Thank you very much.
Thank you very much, madam. That was a brilliant presentation. And now it is time for discussion. We'll have a common discussion on the first and second trimester anomaly. I think Dr. Pratima has already been answering many of the queries. My co-moderators, have you got any questions? You can start.
Yes, Lalita Madam wants to make some comments. We have a few questions from Dr. Pratima. Lalita Madam.
There are a few questions. Should we do first trimester anomaly scan for all? What is the recommendation? There is one.
I think I have answered that question already. Yes, of course, first trimester scan should be done for all, because if you pre-select, then you are going to miss out on many abnormalities that could present in so-called low risk. In fact, the low risk women are the most likely to have a high risk fetus. So yes, screening scan should be done for all, because we also know that the first trimester scan is not just a nuchal scan or not just a Down syndrome scan anymore. Down syndrome screening is a very small part of it. We're looking at defects, we're looking at preeclampsia screening, we're looking at growth restriction screening. So we're looking at so many things which are far more commoner than aneuploidies. So yes, it should be universal screening if your aim is to pick up as many problems as you possibly can and reduce the perinatal mortality and morbidity.
Is it 11 to 14 you mean, or before that?
Well, the risk assessment for chromosomal abnormalities is between 11 to 14 weeks, which is basically 45 to 84 mm. But if you know, there will be times when the woman will come late, and she might come at 14 plus 4 days, and the previous scan was at 7-8 weeks. So you can still do the scan. You cannot do the risk assessment for chromosomal problem. You can still do everything that I said minus the risk assessment, but you can advise them to do serum screening, that is a quadruple marker screening from 15 weeks. You can check and make sure that there are no major structural defects. If she requires NIPT, then you can plan the NIPT as well. So yes, you can do it later also, but for risk assessment for chromosome, it is done between 11. But if she comes for the first time at 15 weeks, please do the scan. Don't ask her to come back at 20 weeks. Do the scan.
What about before 11 to 14 weeks?
Well, that's the early pregnancy scan, isn't it? Because majority of the people do the early pregnancy scan, but I would be very hesitant to report too many abnormalities at that stage because the evidence is not there as yet. Although people do looking at things, but I think that would be a good dating scan. But it depends what the aim of your scan is. Your aim of your scan is to screen for chromosomal abnormalities, detect structural problems, screen for preeclampsia, screen for growth restriction, and reassure vast majority of the couple, then it should be done at 11 to 14 weeks, which is, you know, for structural anomalies and things like that, you can do after also. But it depends what the aim of your scan is, right?
Will the double marker and triple marker change with singleton and multiples?
First of all, we should not be doing triple marker at all. So let it go away. Let the triple marker go. The double marker has moved on to become the quadruple, first trimester quadruple marker, because you can include the PLGF also and AFP also, which will be done along with your first trimester scan. So it can be done at the time that you're doing the NT scan, or the quadruple marker can, the risk assessments can start from 35 mm of the fetus. So you can start doing it at 10, 11 weeks. So one option is you do the bloods at 10, 11 weeks and scan at 12, 13 weeks and combine the whole thing, or you can do it at the same time as you're doing the scan as well, the first trimester scan.
And a twins.
That is why we're not calling it the NT scan anymore. We call it the FT scan. It's the first trimester scan, because it's not just the NT. NT is a very small aspect of the first trimester scan. So I think we have to move on from calling the NT scan as the first trimester scan, then everything becomes inclusive.
What about these markers in twins?
Markers in twins, of course, you have to look at markers in twins. You do the serum screening also if there is concordant twins. But if there is discordant twins, the problem with the biochemistry is you don't know how much beta-HCG, PAPA, etc. is being secreted from the abnormal placenta, and whether the normal fetus placenta is neutralizing it. So I would avoid using serum markers, which includes the NIPT also to some extent in babies with discordant markers. So discordant marker babies, discordant anomaly babies, they are better off with doing invasive, especially in the first trimester, because by doing serum markers, even NIPT for that matter, one is you cannot be certain the abnormalities coming from which baby. Secondly, you know, it can take 2 to 3 weeks for the results to come, which takes you to 16, 17 weeks. And if there is indeed an abnormality in twins, fetal reduction done in the first trimester has got better outcomes than fetal reduction in the second trimester. So I think even more important to do the first trimester scan in multiple pregnancy.
Can you differentiate with monochorionic, dichorionics?
Absolutely very important to differentiate between monochorionic and dichorionic, because in dichorionic you have two separate fetuses with two separate
in terms of the serum markers.
Yes, that's what I'm telling you. Yeah. You have to include the factor that it is a dichorionic or monochorionic pregnancy in your risk calculation. So either if you have the Fetal Medicine Foundation software, it will do it for you, or the laboratory should do it for you. So you have to ensure that it is reported either monochorionic or dichorionic, and therefore the laboratory will include that when they do the risk calculation. Of course, in dichorionic, there'll be two separate risks for the babies. In monochorionic, it'll be a single risk which includes both babies. Having said that, in about 1 to 2%, we are realizing more and more you can have two different karyotypes even in monochorionics pregnancy, because of the splitting of the cells and things like that. Particularly, you can have one baby which is completely hydropic and the other baby is normal. Sex chromosomal aneuploidies can be different, and even genetic abnormalities can vary. So you have to be cautious. I mean, doing blindly serum biochemistry for everybody is not the answer. You have to select which fetuses will benefit when there is discordancy, whether it is monochorionic or dichorionic. Of course, when you have concordance, that means both the babies looking similar and things like that, by adding serum biochemistry, you will improve the the detection rate and reduce the false positive. So if they're concordant, go ahead and do the serum biochemistry. That will be helpful. But if they're discordant, you have to really be more cautious and be careful. I prefer not to use the serum biochemistry. I would go in straight for invasive, or as I said, if you want to do reduction, reduce the abnormal and make sure the normal baby is chromosomally normal as well. So we have to discuss these options with the couple.
Sangeeta, any questions to Indrani, madam?
Thank you so much, Indrani, madam. It looks like 18 years ago, and the crystal clear way you spoke. And especially, I love the part about the counseling and how we really need to be evidence-based. I have two questions for you. there is something on small single isolated anomalies like bilateral pilectasis or small ventriculomegaly where the atrial width is less than 1. We don't find anything else. It's just this anomaly or probably an echogenic focus in the heart. And very often patients, the counseling is probably the most important thing. We know in our minds that we are not going to terminate that pregnancy. So how do we really counsel these patients as to what to expect?
So actually, that is a part which I did not cover in my talk. Even though I told in the introduction, we separate as normal and then abnormal. In between, you have a group where you called as either soft markers or borderline findings sometimes. It is important and try and see whether you can push them to normal side or to the abnormal side. So for all that, when I have ventriculomegaly, if you think 10 millimeter on up to 9 millimeter is normal, anything from 10 millimeter. If you look 10 to 15 is grouped as mild ventriculomegaly, but then we need to, can you hear me?
Yes, ma'am. Yes.
Yeah.
You can hear.
We need to look into the extended cranial imaging and extended imaging of the fetus, and also some certain things like make sure that the chromosomes are normal and do basic infection testing and tell them there, because what way the fetus can move on. So usually when the ventriculomegaly is a mild one, still there is a percentage of them, they can show some additional findings during growth scan, and those are the percentages we need to talk to them. Coming to pilectasis, this is less troublesome compared to your ventriculomegaly. So pilectasis also we have our grading by either you go by the urinary tract dilatation grading by consensus statement, which we follow. That is from 4 to 7 is grade 1, and then from 7 on, depending upon which trimester you are in. Because the pilectasis marker aneuploid. So you can, otherwise the lady has had a first trimester scan and screen negative, or there are no other aneuploid markers, we can just forget the association of pilectasis and chromosome, and rather than focus on the evolution of that particular dilatation. Is it going to become big? It is going to require any assessment postnatally. If you see milder dilatations, they usually do well. The percentage of them progressing on to problem in either in antenatally or postnatally is very small. But whereas when you group this urinary tract dilatation 2 and 3, where you have calyceal dilatation, where you have bladder problem, or you have your ureters, you are able to visualize, those are the ones you have to be cautious when you are counseling. There is more chances for evolution of changes, but then we need to wait and follow up the pregnancy, depending upon what the baby is showing. And it is important in all these cases, when you have a pilectasis and it is significant dilatation, say in the mid-trimester 7 or 10 millimeter, we need to do again an extended renal imaging. Everywhere, the particular organ system as well as rest of the fetus, you see, what is the tool that you use for extended imaging? We used to pick up the highest transducer frequency that is possible for that particular subject. And then look at the medulla, cortex, any cortical cysts are there, and then the bladder wall thickness, how nicely the baby is emptying the bladder, all these stuff. Also, even though we don't divulge the gender of the baby, but I make it a point to look at the perineum. I just say, ask my colleagues also, my junior colleagues will be there. We should not utter that banned word. So I tell them, kindly look at the perineum, or I will say, look at the perianal muscle complex. Anyway, we are looking at it as an additional one to rule out high anorectal anomaly. Look at the perineum, look at the anal complex, you will be seeing the external genitalia. If it is going to be showing some problem, then accordingly we need to take. Otherwise, if it is just UTD 1 or 2, you don't have to get anxious about it. The third thing you said, the other marker is the echogenic bowel. Again, the same thing. As an aneuploidy marker, the likelihood is little higher compared to pilectasis, but still, no, if aneuploidy screening has been done You don't have to worry. You need to concentrate more on the local structure, how it is going to develop, and also as a marker for infection or cystic fibrosis. But there are few things, we cannot say cystic fibrosis is not there, but then we can't be screening for cystic fibrosis because echogenic bowel appearance, it is difficult. Even though you say grading and all that, we can just say if it is a hyperechoic bowel comparable to the bone. Because with this much of experience, I say more than more. How can you say white and more white? So it is difficult. So if you have an echogenic bowel, then you look at how the bowel is going to develop. Another thing we need to observe also, what is the machine you are using? If you have a thin subject and you have a very good machine, all second trimester bowel will appear echogenic. This is a problem I am getting now. Lot of second opinions coming. Because to convince them saying that it is normal, it takes more time than talking to a patient who has really an abnormality. So these are the things we look into. So once you have any of these findings, you need to have your cross consultation with the fetal medicine person who has done the scan and then rule out. Then you can give the reassurance and follow it. And also we need to remember the fetus is not a small newborn. Its systems are all developing, because while doing autopsy, I have observed so many times in the mid-pregnancy, you can see this bowel filled with a little meconium, small bowel, few loops. They would be little like 7 millimeter. That is why we need to say, because it is in the physiology of propelling the meconium. So you may find little loops of bowel which are little bright or little widened. So these are all physiological findings. Mostly.
Indrani ma'am, Indrani ma'am, with your permission and Pratima ma'am's permission, because we are running out of time, could I just take steps and wind up this session?
Sure.
Yeah.
Thank you so much, Indrani madam and Dr. Pratima.
Yeah.
It has generated
Thank you so much. Thanks so much.
You're running half an hour late.
Yeah, thank you.
I think I've answered quite a few questions. If you can just share it with the delegates, that's fine.
It will be.
Sure, it will be
Thank you. Thank you so much. Have a lovely day.
Ma'am, Lalitambika ma'am, thank you very much, and Ambuja ma'am, thank you for making the session so interesting, informative. And once again, I apologize for being, the bad man out here and interrupting in the middle of this wonderful discussion. But we have been keeping Kurien Joseph sir waiting for a very long time. Sir, you can unmute now with confidence, because the next session belongs to you. And I invite Vinendran sir from Calicut and our own Govinathan sir to moderate and chair the session. Kurien Joseph sir, all yours. Sir, please unmute Kurien sir. And we have myomectomy up there.
You want me to start?
Yes, sir. Before that, can you put your first slide in? Screen share and put your first slide, sir. Do you have your intro on the first slide?
No, I don't have to. I don't need an introduction like that. It's not an issue.
No, I think 1 minute, sir.
All right. Hello?
Yeah, sir. Yeah, I shall just introduce Kurien Joseph sir, or Vinendran sir. Can you please, just introduce sir. Please unmute Vinendran sir and introduce.
I must say that Dr. Kurien Joseph doesn't need any introduction, because he is part of our talks itself. He is not. For all conferences, he will be there, and he is director of Joseph Hospital, and he is a pioneer in gynec endoscopy in India, and he is the president of Asia Oceania Federation of KFOG, then the International Society of Endoscopy, Federation of Obs and Gyn, Vice President 2008, and the organizing chairperson of ASUG 2015 Chennai. And I know you are going to conquer the event of talks today, because a man like you will deliver the substance. Thank you, sir. The screen is yours.
You have to stop sharing.
Sure, please help sir out.
Yeah.
Yeah. Yes.
You can change your slideshow.
Okay. Can you hear me?
Yes, sir.
Yes, sir. Yes, sir.
Good afternoon. Hope none of you are very hungry. Especially, only person I'm worried is Dr. P.K. Sekharan, who's sitting there. He must be feeling very hungry by now. I bring you greetings from Tamil Nadu and thanks for the invitation. We all celebrated a very happy day. Any of you know what the happy day was? Yesterday happened to be Happy Madras Day. Every 23rd of August, we celebrate the birthday of Chennai. And it was Madras. And these are all the lovely, happy pictures of Madras, which you see. If you're in Chennai on those days, you can go around and see the beautiful city with everything around it. So with that in mind, today I've got a lecture, which is basically saying that we try for the moon, but what I'm going to talk about is just basically laparoscopic myomectomy, the key points. Now, I harp on the word key points because laparoscopic myomectomy is very well known to the entire audience there. So I don't really have to go into any points in that. So what I intend doing is first extend my thanks to KFOG team for the invitation. And the entire points which I'm going to talk are just 5 points. I want to emphasize on the fact that you should choose carefully. Second, that you should plan your surgery. Third, reduce blood loss. Fourth, work on tissue removal and HPE, because I find many people remove the tissue and don't bother about the HPE. And finally, I want to spend a word on the wound strength after myomectomy, what we should do with that. So with just these 5 key points in mind, you can be assured that your lunch will not get delayed too much. This is a slide which I've been putting for nearly 20 years, and I still continue putting it. It has reached such a level that if I want to do a myoma surgery in the hospital, my straightaway question is, have you done myoma mapping? Can you see, you can see my video, isn't it? I mean my slides?
No, sir.
Hello?
No.
You can't see?
No, sir.
No, we can see, sir. We can see you.
Yeah,
Sir.
you can. Okay.
We can see the first slide. Greetings from Tamil Nadu. The slide is not moving.
I don't know why. There's some resume. Okay, let me just get out and get in again. I thought everybody's seeing it.
You can see top. You can see view option. There
Yeah,
you can.
stop and put it again. Just give me a minute.
Hello? Sir, madam.
Now it's right.
You can see?
Yes.
Myoma mapping.
Yes.
Yeah.
Okay.
Yes, now we can see. Sir.
Myoma mapping is old as the hills. We insist on myoma mapping because myoma mapping is very, very important for one to try and decide on the choice of your cases. If you don't do this properly, you will not know the size, the number, the location, consistency, and the other most important thing is the associated pathology. How often we see a myoma, go and operate, and then we find there is an ovarian cyst. And when you send that for biopsy, you note there is an element of doubt or malignancy in that ovarian cyst. So this essential aspect of myoma mapping, I think I must insist on. Today to that, we add the LDH and LDH3 tumor markers. A question always asked is HSG is of no use at all. I think we must give it up as far as myomectomy is concerned. So choose your cases carefully, classify. Use the standard FIGO classification available. Mark out all the myomas. And to that, you must get your sonologist friend to go through all the criteria for reporting. The number, the size of myoma, the location on the anterior, the vertical plane, the horizontal plane, the size of the largest myoma, and their relationship to the endometrium. If this is there, then one can go ahead further and proceed with the surgery. So when should we do myomectomy in infertility? is a question which every meeting we've been having. Single intramural myoma, 3 centimeters, leave it alone, sit and watch longer, it becomes 5.5 centimeters. Should we do something? Again, we are in a dilemma. But if it gets bigger, if it gets to around 7 centimeters, she's infertile, she's 33 years old, she's trying for a baby, then of course we would all think in terms of doing a myomectomy. But what about asymptomatic large myomas? If it is beyond 5 centimeters, I think the indication is we should think of removing. But overall, the decision should be based on the patient's preferences and the clinical factors which are available. You don't make a random decision. But there's still going to be confusion. Are we going to sit and remove in general? I think the message is you must individualize as a general principle every single case. If there is cavity distortion, please remove it. Do not try and leave it there. You have to consider a myomectomy if there is infertility, previous failed IVF attempts, recurrent miscarriages, advanced stage. All these criteria definitely fall in place. This is part of the Canadian guidelines. But the important principle of the Canadian guidelines, which I like to always emphasize, is that fair evidence to recommend against myomectomy in a woman with intramural fibroids, hysteroscopically confirmed intact endometrium. That means the myomas are not in the cavity. So in that case, you have to give her a chance to try and conceive, go ahead, deliver normally. And if you're thinking of surgery, then you must weigh the benefits of myomectomy and individualize and then do the myomectomy. So there we have chosen the cases carefully. We have located the myomas. And once we have decided on these two aspects, then we think in terms, today we have a large school who say, just give medical management and wait till the lady thinks in terms of pregnancy. Now this can work in two ways. If you are just going to give drugs like progesterone, GnRH, or mifepristone or ulipristal, remember all these are useful for specific purposes. And most often the purpose is just to delay surgery or to improve the hematocrit. They really do not help in treating the problem so that the lady can go ahead with her life. Also, another point which I just want to emphasize now is uterine artery embolization instead of myomectomy for uterine fibroids. There's even a report as recent as this year from the New England Journal, which says that myomectomy results give a much better quality of life than doing uterine artery embolization. So in both these cases, if the myomectomy is indicated, please go ahead, do the myomectomy. So let's go on to the myoma story. You have a large anterior subserous myoma. It's very large. It's around between 12, 13 centimeters. You can see most of it is subserous. A small portion is intramural. So you first assess the myoma all round. You see posteriorly, you can see the myoma, you see the tubal origin. The myoma is large on one side, so we fix a myoma screw, pull it to the other side, and then see the other side. You can see the round ligament, tube, and you can see the anterior surface is nice and clear. So these are the typical very large myomas which come and worry you. Should it be done? Should myomectomy done? Simple statement, yes, it is far too big to leave alone, and she has pressure symptoms. So we first assess the whole thing and then decide on the site of incision and whether it should be horizontal or vertical. Now with a very large myoma, you can put vertical or horizontal. You can take your incision either way and convert it and proceed. So we have instilled vasopressin for hemostasis. You can see the hemostasis working. And remember, the important message at this point is your direction of traction. Do not try and lift up the whole myoma because it's far too big to lift. So try and push the myoma to the opposite side and get into that plane of cleavage. And as you get into the plane of cleavage, you'll see slowly more and more space is getting. Now, to get hemostasis, I'm using the standard good old methods of vasopressin and bipolar. I identify any vessel coagulated. Vasopressin has given me certain amount of hemostasis, but there you can see there's a larger vein, coagulate, cut. As you do that, the plane slowly gets free. Posteriorly again, I'm freeing the uterine, the part of the myometrium, which I'm going to retain, and the myoma is slowly getting shelled out. So this is a very large myoma, and as we shell it all around, you can see that I'm not wasting my energy lifting up the myoma. I'm just gently shifting it from side to side and working on the myoma. So there we have got into the plane of the myoma proper, and now I've pushed it totally to one side, and I'm carefully moving the myoma off from the myoma bed. So these are the aspects of myomectomy which one should not get sort of overawed by it, but as you give time, you'll find that the myoma tends to come out. You identify vessels, coagulate, I'm using simple bipolar, and cut it and take it out. So this is a simple myomectomy. And once that myoma is removed, you see another one sitting below. Be prepared for the unexpected. Take that myoma out also. Don't say, I can't take it out because I've taken such a big one out already. And suture it, get hemostasis. A word about uterine artery ligation or internal iliac artery clipping. They are very fancy techniques. I've got nothing against it. But my contention is, if you can do it with such minimal blood loss, why should you do all these procedures? I would like to get anesthesia, which is hypotensive, and with that, we should be able to go ahead. So with that, let's go on to the next aspect of the whole thing. Sometimes you get these myomas which are enormously cystic. Here you're looking at a myoma which is around 9 to 10 centimeters, burrowing totally into the right broad ligament. Now again, I believe that you can just identify the ureter. You can see it's gone between the uterus and the ovary, lifting the ovary up. I still give vasopressin, although the effectiveness is limited. Identify the ureter that it is free, and then get into the plane of the myoma to try and dissect out the myoma. Now, if you can do this, you don't have to be worried about the structures around. Once again, simple monopolar, bipolar, get into the plane of the myoma and shell out the myoma. You can see that the myoma comes out quite easily in most of the cases, and one doesn't really have to fight with it. The decision is whether to use a myoma spiral in a case like this. The myoma kept on going down, so we decided we had to keep applying traction with a toothed grasper because the myoma spiral may not hold in the initial phases. But then we saw it going further down and then decided to get the myoma spiral and fix it further down so that we can get the entire myoma coming out uniformly. So that's the myoma coming out. And at this stage, we try and see if there is any blood vessel which is major, identify it, coagulate it, and cut it. Remember, I'm working away from the pelvic side wall. I'm not worried about the ureter because I've gone in the plane and shelled out the myoma. The other concept for a case like this would have been to try and identify the uterine artery, achieve hemostasis. But you can see now the procedure is quite clean and complete. And in this situation with a cystic myoma, I'd like to emphasize that we are very fond of taking myomas out through a simple colpotomy. 8-9 centimeters cystic myoma, catch it with the grasper or the claw forceps vaginally, slowly pull it out and suture the wall to the vagina. Procedure very simple. Patient has hardly any post-operative morbidity. There's no pain from the big morcellator scars. There's no pain also from the incision made on top to try and remove a myoma. So these are options which are available. But then today things are getting more and more troublesome. You choose carefully, yes, it's easy to say. You take the story of this young girl who has been with me for quite some time. What has happened with her is she came to me in 2007. We did a lap myomectomy. There was a 4 centimeter posterior wall myoma. We took it out. In the year 2008 and 2011, she came and did cesareans for obstetric reasons. In 2013, she came for a hysteroscopic resection of a submucous myoma 2 into 3 centimeters. And 2017, again another hysteroscopic resection. She had 3 small myomas. And finally, now at 2019, she has come with an anterior wall myoma 7 into 6 centimeters, a posterior wall myoma, the anterior wall myoma is more submucous, a posterior wall myoma which has got adenomyosis also, and a right iliac region mass 7 into 6 centimeters. So you can see how the things are slowly escalating. She is now 39 years old. I would say 39 years young. She does not want hysterectomy and she cannot take hormones. So these are the situations we are slowly going into. Situations are more complicated and are ruled by our patients, and one has to take decisions. The question that I just want to pose to you is, are we oversimplifying, and is the patient taking advantage of that? Are we landing with the possibility of a malignancy, or even it could be a stump tumor or a tumor of low malignant potential, or other complications could develop in any one of these meddling? Should we sit and emphasize that we must have a hysterectomy, or we continue with the myomectomy story itself? So when do we draw a line in cases like this? Think over all these things, because I'm sure many of you would be landing up in similar situations. Now this lady, we had to operate because she was getting quite desperate, and that's the variant picture. This is her mass in the right iliac fossa. 2007, we had done a lap myomectomy. The myoma was removed through the left iliac port, and this is in the right iliac region, a 7 centimeter myoma. Then you see the uterus, the body of the uterus has got a large anterior wall myoma, and posteriorly there's a smaller myoma. So with this in mind, we go ahead, put vasopressin, and slowly try and take out the anterior myoma. I hope you're able to see that. The myoma shelling out, the myoma is essentially submucous. And because it is 6-7 centimeters, we decided to take everything out through a laparoscopic procedure rather than doing it vaginally, hysteroscopically, and then later on laparoscopically. So you can see that myoma coming out. We're shelling it out, a combination of push and pull. Take the myoma out. Once the myoma comes out, then procedures are simpler. Push the whole myoma out. You can see there's some small polypoidal tissue in the endometrial cavity. We took the entire thing out. So here we are happy that step 1 is complete. So once that step is complete, then we went posteriorly and there's a small remnant parasitic myoma posteriorly there, took that out, freed the adhesions, and carefully kept dissecting out the posterior myoma, which was not such a simple one and which had a big adenomatous component. So we excised that whole portion, and after excising it, we found that we were getting closer to the bowel, so freed a few of the bowel adhesions posteriorly. Once we freed the adhesions, you could see there's plenty of surface for me to work in. Excise that tissue, and once we excised it, we could suture it easily back into position. So the first 2 were sutured, and then we went to that parasitic myoma, which was attached to the anterior abdominal wall, and went ahead little by little coagulating, cutting. You can see that this is a very simple one because we were lucky. Sometimes the parasitic myoma gets embedded in the loop of bowel, in which case we may even have to resect the bowel. So with this, we have separated it. So the dilemma facing us was, how are we going to take it out? We've got 3 essential myoma bits available, each around 7 to 8 centimeters. And once again, we decided that we are essentially fond of the colpotomy and we will go ahead and do it. So this parasitic myoma, is it debris or is it ischemia secondary to GnRH or due to uterine occlusion of a pedunculated myoma, question mark. So how we took it out is the thing. You can see that we again saw free area. You see the raw surface where I'd freed the adhesions earlier. You can see the vaginal ball pushing there. And at that point, we did a colpotomy, freed it. And once it was freed, you could see things are very simple. We are not complicating it. You can see the ball in the vagina, pass a claw forceps through it, and pick up the bits one by one and take it out through the colpotomy. That's the smallest bit we took out first. We had totally 4 bits. That was the anterior myoma. And finally, the big one we pushed in and took it out vaginally. So you can see procedures can be done, essentially looking quite difficult, but one could go ahead and do it. That is the largest myoma, pushed it down. This one required a little more encouragement from below. We had to widen the portal a little bit and take it out. So that was the myomectomy being done. This was at the completion of procedure. We believe in putting an interseed to cover the barrier, to cover the sutures, because we use barbed sutures to fix the wound close, and we don't like that to come in and get exposed to the loops of bowel. So this is the completed procedure. If we are in doubt of oozing, then we would do put a drain in. So that's the procedure incomplete. But if the myoma were larger, if we were worried about pathology, all of you are familiar, we would put it into a bag. This was a large myoma, 11 into 10, and the patient herself was very particular that we do the morcellation in a bag. I'm not one of the big fans of in-bag morcellation because 1, it takes time, and 2, I believe that if we morcellate, if we dissect, keep the myoma out, we may spread the myomectomy, the little bits of myoma which we dissected out. So that's a myoma in the bag, and once it's put in the bag, we pass the scope into it, and then we pass the morcellator into it, and carefully morcellate and take the myoma out. So procedures are possible. Doing in a bag is possible, but I still feel if we are able to get away with doing in a simpler method, we should try and do it. Does the bag prevent the problems? Do we have to do all the other tests even in bag morcellation? Things are still in question mark. Then we go to the problem of multiple myomas. Sometimes the myomas are too many, too big. If anything more than 12 or 14 centimeters, I would personally believe in doing a laparotomy. But here we have a myoma which is around 12, 13 centimeters attached with multiple other myomas. So we just sit and free it. You'll see as we free it, there are more and more myomas attached to the uterus. So this becomes a surgical exercise where one sits and takes out all the myomas who are attached, growing like a family. In a way, these are much easier to do because they come off very much easily. And then we take it out and suture it. But then there is a very important paper by Falcon which says that the more fibroids you remove, remember the chances of fertility getting affected are definitely more significant. If more than 6 fibroids were removed, the incidence of pregnancy can become less. And we are less likely to have a term birth when compared to women with less than 6 fibroids or more. So these were the cases we had done till around 2014. This is what we presented at the FIGO. And out of these cases, we had followed them. We had had about 233 pregnancies. We had a fair number of vaginal deliveries of the patients who came to us. We do not mind waiting for patients to go through in labor if we have done the suturing. But that again puts us on a guarded thing. We are not very confident when some other people we are not aware of suture the patient. Now, we occasionally get cases which are very doubtful. Now, if the myometrium is of a inhomogeneous texture, due to the presence of a heterogeneously echogenic subendometrial myoma. We have done the LDH, marginal elevation, our ultrasound score was 21. Patient was 37. She wanted somehow to try and think of pregnancy, if possible, IVF. So when we looked at it, it was not looking good. Injected vasopressin, unusually white the whole uterus became. Then we went ahead, shelled it out. You could see the entire tissue was beginning to look different. We shelled out more. And as we kept shelling out, you can see it looked more like a large adenomatous mass, but something more abnormal. So we took the entire thing for frozen section, sent it for histopathology. And at histopathology, we found out it was a spindle cell tumor or an endometrial stromal tumor. This lady had to go in for radical surgery, which was done at a different sitting because she was not mentally prepared for doing the whole procedure at the same time. So be prepared for these abnormal tumors. And talking about abnormal tumors, one has to think in terms of the post-operative follow-up of these patients. The HPE of the myoma has to be assessed very carefully. Look for the cellular myoma. It may lead to some abnormality. Look for what we would term as STUMP, the smooth muscle tumors of uncertain potential malignancy. And then look for the leiomyosarcoma. You have to get a mitotic index. You have to get the evidence or the degree of cytological atypia. And you have to look for tumor cell necrosis. All in all, I emphasize that you must get a good pathologist who works with you to try and report on all these things. If this is done, then only will you be able to succeed in your myomectomy procedures. A word about the uterine wall after your myomectomy. Essentially, the incidence reported is greater than after my open myomectomy. But then again, remember that the incidence of lap myomectomy has gone up very much greater, and it's being done by a very, very large number of people. The risk factors were assessed very nicely by Parker and others. It was some time ago, where they said that if you adhere to the techniques developed for abdominal myomectomy, including limited use of electrosurgery, I mean limited use, not don't use, and multi-layered closure of myometrium, your individual wound healing is good and you will get good results. But occasionally there are reports of cases with abnormal ruptures present. And this is an unusual rupture which was presented by an Italian from Bari. At an ultrasound scan, they found the pregnancy around 32 weeks. And as they were assessing the uterine wall, they found that there was a loop of cord protruding out of the incision. Very, very unusual. And when they turned on the Doppler, they could see that the blood vessel was sort of going out and coming back in. So this was a silent rupture from a patient on whom they had done a lap myomectomy at the region of the isthmus. So all they could do was to do a laparotomy, deliver the baby and close the rent here. So this is a lucky case. But overall reports of rupture uterus were very limited in large studies like Ornella Sizzi, Malzoni, and all the others had very, very few. Even we have not had a rupture from a myomectomy in a patient, even though we've left them in labor. So rupture need not scare you if you have been careful in closing the uterus. And when you close the uterus, I emphasize that you must get the layers of uterus together. Don't take the serosa and put it deep inside. That means the strength of the uterine muscle wall goes. Take one layer inside, take the second layer, you find the whole thing healing very much more effectively. So in conclusion, I'd just like to say that laparoscopic myomectomy is clean and a safe procedure, but has to be treated with respect. And I just want to leave you with your key points. Choose carefully, plan surgery, reduce the blood loss, be careful at tissue removal, and remember that the wound strength after myomectomy is very good. I'd like to leave you with the words of one of my heroes, Rafael Nadal. He says, don't practice till you get it right. Practice until you can't get it wrong. That means you must really work it out. Otherwise, you cannot do that well. And so thanks for the nice opportunity. And let's spread happiness with our endoscopy by doing good. Thank you for your patient listening.
Very informative and with very practical tips for the practicing endoscopist. Thank you very much. I think there are no questions. Chat box.
Yes, there is one from Paili sir. For mapping, do you rely only on ultrasound scan or use MRI? Is there any confusion with adenomyosis? If there is a suspicion of adenomyosis, would you like to go ahead with an MRI also?
I would always use an MRI if it is multiple myomas. If there's a doubt in my sonologist's mind about the borders of the fibroid, thinking of adenomyoma, it's definitely better to get an MRI. Okay.
And as you said, sir, if there is an IVF failure with a 3 centimeter fibroid intramural, you will definitely go for the surgery.
3 centimeters is still sitting on the border, Vinay. I'm not very, even recently I had a 4 centimeter in a lady who had lost a child, who was going in for IVF. I told her, try again. 3, 4 is still very, very doubtful. I'm not very convinced. Each patient I would individualize.
In such situation, will you try medical management prior to?
No. Because 3 centimeters I know is not, if it is not involving the cavity, I'm quite okay with doing IVF in that case.
Okay.
I know there are 1 or 2 papers which say that if there is a myoma within 1 centimeter of the uterine cavity, the possibility of a pregnancy loss is there. But I'm really not convinced. We have had enough number of patients with fibroid going through with pregnancies. It's a controversy.
Another question. Up to what centimeter size of the fibroid you will prefer to go for colpotomy?
Anything up to 10, 12 centimeters we do colpotomy.
And even size is more if the texture is more important.
Correct. The texture is the more important thing than the size. Because if it is soft, you'll find like that myoma, which was 7, 8 centimeters, it went in nicely into the pouch and we could take it out easily. Whereas if it is calcified, it's not going to come down. Those are the cases where we struggle and we may end up doing other things. If absolutely no other option, yes, extend the incision and take it out abdominally.
Yes, sir. What about the number of myomas for laparoscopic surgery? Is there any?
Up to 10, 15, yes. I don't believe in taking the 40 to 100 and all that. I prefer doing it abdominally.
Yeah, sir.
It takes too much of time. I'm not a very big fan of it. Because the thing is, we have done open myomectomies before. There are many people who have not done open myomectomies who are very hesitant. But the time taken is definitely a factor. I don't think I will do it laparoscopic.
Thank you, sir. Thank you, sir.
Thank you.
Kurien sir, thank you very much for the excellent talk.
Pleasure, Venugopal. Anytime you say, no issue. Absolutely.
Even though there are a lot of endoscopy meetings going on, sir, it's always a pleasure hearing you. And we keep our meeting for the ordinary gynecologist, helps them to make decisions and, in day-to-day practice. All the talks are like that. Thank you very much, sir, for I think those who heard I am told close to 2,000 people logged in when you spoke just now and were hearing your talk. So
I think KFOG is very popular. Full marks.
2089.
2018. Yeah, sir. Means they must say whatever it is, but
even if 50 people are willing to hear, I am willing to talk. Don't
yes,
worry
sir.
about that.
Thank you, Vinayan sir, and thanks Gobinathan sir also for being present, chairing, and making the session interactive. Ajit sir, I request you to wind up our day's proceedings, and Ajit sir is of course our next KFOG president, so probably he's borrowing few tips about how to run.
Thanks to Ambujam madam because she's the one who called me and told me.
Yes, I'm so thankful, sir. You readily agreed, and we are honored.
I hope the next president will be not on web.
Hope so.
Please wrap up the concluding for the day for us, sir, so that I request Ajit sir to wrap up the proceedings.
Respected seniors, dear friends, I would like to thank all the speakers and moderators, especially on this Sunday morning, taking all your time out of your busy schedule. And I consider it as a privilege and honor to give a closing remarks. Especially, I should thank Ambujam Madam and Dr. Venugopal for giving me this opportunity. And I thank all the senior faculties and dear friends and all the delegates for attending this meeting. And another thing is I would like to thank is the sponsors, the
Sun Pharma.
division of the Sun Pharmaceutical. And I think Hari is there.
Hari, Hari and Hari.
Can you unmute and say a few words?
Hari.
Good afternoon, dear doctors. On behalf of Sun Pharma Sanor Division, Kerala, I thank Dr. Will, sir, Dr. Ambujam Madam, and all of his bearers of excellent sessions. I'm sure all of you had a good learning time. And I extend my sincere thanks to each of the participants who made the program you all very advanced. Regards, sir.
Okay, thank you. Thank you, Hari. Thank you once again, all the faculties and all the moderators and speakers.
Yes, also Sapan and Kishore, technical help. We share your grief that Pratap sir, I think we once again apologize to him. Sapan, where are you? And Kishore, thank you very much for guiding us through this. And even at the end of the show, we say means a word of apology to Pratap sir because there were some technical glitches. But Kishore, are you there? Great
Yes,
job.
I'm there, sir.
Yeah, great job. Thank you so much
Thank
for
you.
seeing us through this. After all, we are medical people, so we need your help and this thing. Thank you so much.
Definitely, sir. Anytime. Thank you. Thanks for the opportunity, sir. From
Okay, and finally, I should also thank my secretary, Venu, who is actually the brain behind all this. So he usually comes up with novel ideas and speakers and everything. And actually the background work is all done by Dr. Venugopal. So thank you, Venu. Thank you, everyone.
Somebody's behind the stomach.
So you can have a virtual lunch.
Thank you all. Thank you. Till we meet again. Thank you very much.
Thank you.
Thank you. Nice. It was very nice.
Yeah.
Thank you. Thank you.
Thank you. Thank you.
Thank you.